Major trauma part 2. So it is a continuation of the previous class. First, what we'll be seeing is the burn. Burns can be because of increased heat, so thermal burn. It can be because of chemicals, or it can be because of electric, or it can be because of radiation, or it can be because of exposure to extreme cold. Mainly today, what we'll be looking for is the thermal burns. Thermal burns, how to manage the thermal burns, what we'll be looking for. Rest of the burns we'll be looking for in different chapters like environmental emergencies, and in toxicology we'll be looking for. In children's and vulnerable adults, it is always important to keep in your mind that it can be a non-accidental injury. Do not rule out a non-accidental injury because it is a burn. Okay, in children, especially if you're seeing a burn which is a shape of an instrument, for example, it appears like a cigarette burn. You need to always think it can be a non-accidental injury. First, you'll be assessing like any emergency case in the manner of A, B, C, D. That means first you'll be looking out for airway, followed by breathing, circulation, and deformity. First, what we are looking for is the airway. In airway, early intubation might be required, also known as prophylactic intubation, mainly because if there is a burn of an airway, swelling can develop. If swelling develops, it becomes very difficult for you to secure an airway. It will compromise the airway, the patency of the airway, but you may not be able to secure the airway. You might require an front of neck access. For that particular reason, you need to look out for subtle clues which indicates that you need to go ahead and intubate this patient prophylactically. For example, if there are any signs of obstructions like hardness of voice, stridor, use of accessory muscles, a sternal retraction is present. Extent of burns. If the total body surface area which is involved because of the burns is more than 40 to 50%, then you will go ahead and intubate those patients. Deep facial burns. Remember that it is the deep facial burns, not the superficial. It's partial or the deep, mainly the deep facial burns we are really worried about. Then you go ahead and intubate. Any burns you notice inside the mouth or any soot you notice inside the mouth. Significant edema or risk of edema is present. Difficulty swallowing. You have difficulty swallowing because there is an swelling which has developed. Signs of respiratory compromise suggested by inability to clear the secretions, respiratory fatigue, poor oxygenation or ventilation. A low GCS of less than 9 in any circumstances, you need to go ahead and intubate the patient. You're anticipating the patient needs to be transferred to an burns unit, and it might be in air ambulance you're transferring, or it might be an ambulance and it is a long transfer what you are having. At that point of time, it might be preferred to intubate the patient before you transport the patient. Remember that when you are trying to secure the airway, an endotracheal tube of at least 7.5 mm is preferred. The internal diameter should be at least 7.5 mm, what the ATLS guidelines recommends. In children, it is recommended at least 4.5 internal diameter of the ET tube should be present. When you can suspicious of obstruction or an inhalation injury, when you suspect there is an inhalation injury, when there is an hardness of voice, any respiratory distress, black color sputum, also known as carbonaceous sputum, any burned nasal hairs or the facial hairs, inflamed oropharynx, burns over the face. This is not the simple burns what we are talking about, not the superficial burns. It is the deep burns what we are talking about. History of burns in an enclosed space or a raised level of carboxyhemoglobin levels, that is carbon monoxide levels, are on the higher side. These are also indication to go ahead with an early intubation. So remember, this one also is tested in previous exams. Next, we are coming to the breathing. Breathing, it is always advised that you start on high flow oxygen. Later on, you can titrate it down. Why? Because sometimes it might be an carbon monoxide poisoning might be present because it is a burn. Burn might be because of burns of wood. Basically, the soot he might have inhalated, leading to carbon monoxide high levels, leading to carbon monoxide toxicity. For that particular reason, it is always advised that you start on high flow oxygen. Later, you can titrate it down to appropriate saturations, what is required. A patient with high likelihood of an smoke inhalation injury should be with an significant burn should be intubated. For example, in children who has an body surface area burn of more than 10%, or in an adult who has an body surface area more than 20%, should get intubated. When I say 10%, in the pediatric age group, it is less than 10 years age. or in an elderly person who is more than 50 years age group. So at more than 10% total body surface area involvement in two age groups, what we'll be looking out for, less than 10 years or more than 50 years age group. In an adult, it should be more than 20%. Then you go ahead and intubate the patient if you're suspecting this patient might have and smoke inhalation. Circulation, always get an IV cannula in, get an creatinine kinase levels in, because muscle breakdown is very commonly seen in circulation. So while you're sending for blood investigations, get an CPK done. CPK stands for creatinine phosphokinase. Then you need to calculate the extent of burns, because we usually resuscitate with the fluids in burn patients because there will be significant amount of fluid loss. To resuscitate, we use Parkland formula. In Parkland formula, total body surface area which is burnt is required. So you need to know how to know what percentage of the body area is involved. We usually use rule of 9. Look broader chart if they want to use, they will provide with a chart, they'll provide with a picture, then it becomes very easy. But they want you to remember the rule of 9. Rule of 9 is important. The anterior part of the head is taken as 4.5, whereas the posterior part is taken as another 4.5. So entire head and neck is taken as 9%. The entire upper limb taken as 9%. That is anterior part as 4.5, posterior part as 4.5. Upper back 9%, lower back including the buttocks is taken as 9%, chest is 9%, abdomen is 9%. The anterior part of the lower limb is taken as 9%, posterior part of the lower limb is taken as 9%. So total it will be 18%. In pediatric age group, it is different, mainly because of the large size of the head. The anterior part of the head is taken as 9%. The posterior part of the head is taken 9%. Total of 18%, just the head and neck will take up. Upper limb, it is similar to that of the adults. Total is 9%. So anterior part and the posterior part is 4.5, 4.5 respectively. Chest is also same as adult 9. Abdomen is also same as an adult as 9. Upper back and lower back is taken as 13, but the buttocks are excluded. Each buttock is taken as 2.5%. Lower limbs is not given 9 plus 9. Here it is anterior and posterior part 7 and 7. So total will come up to 14%. That's the difference where we do not take 9. Here is also a difference where we take it as 13 upper back and the lower back. This you need to remember. It is important to calculate. Before we go into the calculation, few more things you need to be aware of is the classification. What is the classification which you need to be aware of? Just the redness, what you are seeing is known as superficial burn, where only the epidermis is involved. It can be quite painful. Okay, not very painful, it can be painful. Next, we'll go for full thickness. In full thickness, epidermis, dermis, and subcutaneous tissue are involved. So it appears like a leather and it will be quite painless. They'll not have any pain at all. They'll not feel any pain at all because the nerve endings are also burnt here. So nothing can carry the sensation. There are no nerves to carry the sensation. In between, what we are having is known as partial thickness burns. It can be a superficial partial thickness burns, or it can be a deep partial thickness burns. In superficial partial thickness burns, epidermis and upper layer of dermis is involved. In deep partial thickness, epidermis, upper and deeper layer of dermis is involved. The main differentiating factor in this two is if you apply pressure, it blunches. Okay, blunching is present on applying pressure. Here, there is no blunching is present. In both, blisters can be seen. Both can be quite painful because nerve endings are exposed here. So it will be very, very painful. So very painful is superficial partial thickness and deep partial thickness burns. Kind of in between is superficial burns. No pain at all is a full thickness burns. It appears like a charred skin. It appears like a leathery skin. That's the differentiation factors what you need to be aware of. Why we need to be aware of? When we are calculating the total body surface area of the burn, we are not including the superficial burn. We are just including the superficial partial thickness and deep partial thickness and full thickness. Superficial, where only epidermis is involved, that part is not included while we are calculating for the total body surface area. In adult, if it is more than 15%, in pediatric age group, if it is more than 10%, then fluid resuscitation is required. Doesn't matter if the patient is in shock or not in shock. Okay, fluid resuscitation is required. Doesn't matter if the patient is not in shock. Also, we give fluid resuscitation. What in shock, what you do is like any other patients, you will state with boluses of 500 to 1000 mils. In pediatric age group, you give 10 ml per kg. What we have done previously for any registration is the same thing. If there is no shock present, then you use modified Parkland's formula. So what we are discussing now is the modified Parkland's formula. In modified Parkland's formula, if it is an adult, you are using 2 into body weight into total body surface area, where you are only including the full thickness and the partial thickness burns, not the superficial burns. If it is a child, you're using 3 into total body weight into percentage of total body surface area of burn. In infants, along with the same formula what you used for the pediatric age group, you will start the maintenance fluid with an DNS, that is sugar containing solution, that is dextrose basically infusion is required. In electrical injuries or electrical burns, you will increase it to 4 ml. That is 4 into body weight into percentage of total body surface area, what will be involving. What you're calculating is the fluid for 24 hours. Half of it should be given over 8 hours. Next half should be given over 16 hours. Next half needs to be given. This also you need to be remembered. Very important. Most of the time, the fluid what you're giving is mainly to start the fluid. Once you started fluid using the modified Parkland's formula, then you will be closely monitoring the urine output. The target urine output in adult is 0.5 ml per kg per hour. In pediatric age group, it's 1 ml per kg per hour. In electrical burns, it's around 1 to 1.5 ml per kg per hour. If you're not having enough urine output, then you might have to increase the infusion rate of the fluid what you're giving, so that you have this is the target of the urine output. If required, you'll increase the infusion. If required, you'll decrease the infusion. You need to meet these targets. So only to start, usually most of the time we use the Parkland formula. Once we start infusing the fluids, we use the urine output actually to determine whether to increase infusion or decrease the infusion. This is the registration path what you're having. Most of the time, it might not be extensive burn, just burns over the hand or over the forearm, over the arm, over the leg. That is the most common presentation to the emergency department in the minors. What you'll be doing? First thing, the limb which is involved, remove any jewelries are present. It might be rings or it might, sorry, it might be rings or it might be bangles. Just remove the jewelries what are present, a finger ring, a bangles, because if the swelling develops, it becomes difficult. It can cause constriction and it can cause compartment syndrome. For that purpose, you need to remove anything which can cause constrictions. After that, remove the clothes. Clothes which are loose fitted clothes, you can easily remove it. But the ones which are adherent to the burn or melted, do not forcefully remove it. The skin will peel off when you're trying to remove it in that manner. After removing the clothes, after removing the jewelry, then you are irrigating. You are irrigating with cold water, basically room temperature water, what you'll be using. And you'll be irrigating for 20 minutes. A normal tap water is sufficient here. You will be continuously irrigating for as long as 20 minutes, multiple times tested. This is an important point. Do not forget. Once you have well irrigated, then you cover it with a cleansed film. Cleansed film is a transparent film what you are having. Usually, it is recommended that before you cover it with a cleansed film, apply antibacterial topical agents. Do not use any antiseptic agents here. Just apply the antibacterial topical agents and use and cleanse phlegm. Cleanse phlegm is used because reassessing the wound becomes easier. You need not remove the dressing to reassess the wound. If some specialist comes, for example, a burn specialist comes, he want to reassess the wound, then he can just look at the dressing what you are having and reassess it. He need not remove the dressing what you are having. For that particular reason, it is always advised you use and cleanse phlegm. Use an antibacterial topical agent is preferred. Antiseptical agents are not proven to be effective. Do not use it. Do not break any blisters if they are present, especially in a partial thickness burns. Blisters can be present. Do not break the blisters. If it is an electrical burn, do not forget to get an ECG. If the woman is pregnant, always assess for the fetal well-being. You can assess it if you're qualified enough to do it or if you're confident enough to do it. Otherwise, you will be taking an OBGYN. Basically, you're taking an opinion of the OBGYN. Fetal, why you are worried in electrical burns? Because the amniotic fluid is a very good conductor of the electricity. So fetal well-being might be hampered. Even reports are there that it can cause sudden death of the fetus. For that particular reason, you should always take an OBGYN opinion, or examine and see whether the fetal heart rate is present, movements are intact there is nothing has caused because of the electrical burn. Electrical burn, superficially we are touching here. Severe electrical burns can have contractures of the affected extremity, and you may not see the contracture, you may not see the any obvious external wounds, but muscle contraction might be present. You need to suspect there's a significant amount of internal burns what this patient has suffered. Okay. Sometimes there will be entry and exit wound. Always look for entry and exit wound if it's an electrical burn what you're having. You might have to admit the patient if any one of the following is present. That is, in loss of consciousness, high voltage means more than 1000 volts. Any new ECG changes if present for that patient. Any arrhythmias are present. If any of these are present, you need to admit for cardiac monitoring. So it is a must. So these are the indications for admission for cardiac monitoring. Fluid, as we discussed previously, we give an increased amount of fluids in an electrical burns, that is 4 ml per kg per percentage of total body surface area of the burn. Remember that you are just including the partial and full thickness. Superficial burns are not included while you are calculating for the total body surface area. When do you refer for the specialist? You refer for the specialist if the total body surface area involved is more than 10%. Though British Burn Association says 2 or 3, nowadays they kind of recommend 10%. 2 or 3% is more. Most of the individuals, they will have 2 or 3%. A smaller burn, how to make out what is the body surface area involved. If the palm of the patient is the surface area of the burn, that is taken as 1%. So palm of the patient is taken as 1%. If that is the body surface area involved, take it as 1%. 2 palms, 2%. 3 palms, 3%. In that manner, you'll take it. So if it is 10%, then you need to refer it. Full thickness burns or circumferential burns needs to refer. Any burns which are not healing over 2 weeks time, you need to refer. If you're suspecting a non-accidental injury, refer to the burns unit within 24 hours. If the burns is over genitals or feet or perineum, you need to refer it. You will talk to the burn specialist. In few circumstances, you may not refer, you just talk. That means you just discuss with the consultant of the specialist burn care services. All burns over the face and hand, you will be just talking to them. All right. Chemical, electrical, and friction burns are also, you will just call them and you'll just talk to them. Cold injury, that is extreme cold, frostbite, what we are talking about, you need to talk to them. A kid who is unwell, febrile, unwell kid, or you're worried about the comorbidities of the patient, which can hamper the healing of the patient. For example, he is an immunocompromised person, or uncontrolled diabetes, or he is on immunocompromised, immunosuppressant drugs for cancer. Those patients, you need to suspect that the healing will be affected. So you need to refer those patients also. Okay, you can read much more about the British Burn Association here. The link is given here, but this is what is required for the exam and the practice. There is a criteria for transfer according to the ATLS also. I do not recommend this one because this is more for US related. We do not follow this. We follow the British Burn Association. Now, dental emergencies we are entering into. First, you need to be aware of the structure of the tooth. The innermost part is known as pulp. The middle part is known as dentine. The outermost layer is known as enamel. If the fracture of the tooth can be classified into type 1, type 2, type 3. In type 1, only enamel is broke. In type 2, enamel and dentine is broke. In type 3, even the pulp is involved. This is the classification of tooth fractures. Evel's tooth. Very important. Evel's tooth means entire tooth has come out. What you will be doing with this entire tooth. This is known as root, okay, or pulp. A root or pulp, basically root, it is known as, this is known as crown of the tooth. This is the actual tooth which is seen externally. This is the internal part of the tooth, what we are having here. Whenever you see these patients in out of hospital settings, for example, you are in a park and a kid has fallen down and a tooth has avulsed. You are in a mall, a kid has fallen down and tooth has avulsed. At that time, what you will do, you need to transport that tooth to the emergency department as soon as possible along with the patient. How do you transport? The best method is to place the tooth in the buccal fold of the same patient and transfer it. If for some reason you're not able to place it in the buccal fold because it's a bad facial injury, you are afraid that because of the low GCS of the patient, he might aspirate it. At that point of time, you can place it in a glass of milk and transfer it. Those are the two ideal medium to transfer it. The best one is to place it in the buccal fold. The second best one is to place it in the milk. Once the patient is in the emergency department, then what you will be doing it? You will be gently handling the tooth. Never hold the root part. Never hold the root part. Just hold the crown part. If there is any debris, if present, gentle wash using a normal saline. What you will be doing it very gently. You will be trying to clean it. Then re-implant it as soon as possible. So anatomically correct position, you will be placing the tooth and secure the tooth. Securing the tooth can be done with a mouth guard or with an foil. You will be securing the tooth. Once you have secured the tooth, think of tetanus prophylaxis. If required, you will be giving tetanus prophylaxis depending on the tetanus prophylactic status of the patient. Antibiotic is always preferred to be given because it always the adult's tooth will be contaminated. You are implanted into the mouth. Chances of infection are very, very high. So it is recommended that you prescribe prophylactic antibiotic in these patients. Then you will be referring to the dentist. One more point you need to remember is you need to try to implant it as soon as possible, because after 1 hour, if it is greater than 60 minutes, or after 1 hour, if you try to implant it, chances of failure is on the higher side. So it is recommended that if it is more than 1 hour after the implantation, if the presentation is after 1 hour after incident, it is not recommended to implant it back, because chances of infection are so high that it is not recommended. If you see the pros and cons, the benefit of replanting is not much, because failure is on the higher side, infection is on the higher side. So it is not recommended to implant the tooth back if it is more than 1 hour from the incident. Dentist has already extracted the tooth. What are the presentations after tooth extraction? They can come to the emergency department. One with the bleeding socket. So the clot has come out. So they had removed the tooth, the bleeding had stopped because of formation of a clot. If the clot has got dislodged because of an infection or something, remove the infected clot if it is present. Roll up a gauze piece and ask him to bite. Okay, that with the compression, he should be able to stop it. With the compression, it is not able to stop it. Same rolled up gauze, what you are having it, soak it with adrenaline. Adrenaline is a powerful vasoconstrictor. Do not dilute it. Just use the ampule and place it there and ask him to bite again. If that also doesn't stop, you might have to use an matrix suture to stop it. Then you will be referring to the dentist. After 3 to 8 days of tooth extraction, they can present it with pain. Quite a severe pain they usually present it with, because the bone, underlying bone, which was there, it is exposed. If this bone is exposed, usually overlying infection will stimulate the nerve endings of the exposed bone, resulting in severe pain. What you'll be doing is you will irrigate with normal saline. Again, important point, I think thrice has appeared in the previous exam. So it is again important point what you need to remember this. Then because of an infection, usually it happens. So oral antibiotics should be sufficient along with an oral analgesia, and then you'll refer to the dentist. Only indication to admit is if the patient is really sick and septic markers are hitting. What are septic markers? We'll be learning in the next classes. But if the patient you're suspecting to be in sepsis, then only you're admitting, then admission is not required. You'll just refer to the dentist later on. Follow up with the dentist. Oral antibiotic analgesia should be sufficient. Toothache, one of the common presentation to the emergency department. Toothache, what you will be doing for toothache? Prescribe some painkillers. Along with the painkillers, if you're suspecting there is an infection, then antibiotic is required. Otherwise, no antibiotics are required. Do we need to admit? In few circumstances, you need to admit this patient. For example, if the patient has a gross swelling, the entire cheek has swollen down because of this tooth pain. Difficulty in opening mouth known as trismus is present. Difficulty in swallowing, suggesting of significant swelling in the mouth that might have caused narrowing of the airway. That's why you need to admit. Systemic infection means severe infection hitting septic markers. Then you need to admit this patient. For IV antibiotics, then you'll be referring to maxillofacial surgeons. They're also dentists. Maxillofacial surgeons are basically dentists who are super specialized. So you will be referring to them. So remember, only oral analgesia. If you're suspecting an infection, then only you're giving antibiotics. These are the indication for admission. If you're admitting, you intravenous antibiotics and maxillofacial reference. Before you give intravenous antibiotics, always send for blood cultures, which is very important. Send for blood cultures before you start intravenous antibiotics. Now we'll enter into the recall questions. Anyone has any doubts, you can ask me. The chat box looks empty, so we'll jump into the recall questions now. So first 8 hours, half, then rest is in next 8 hours or 16 hours. 16 hours. Next half is in 16 hours as mentioned. First half you are giving the Parklands for modified Parkland formula what you are calculating. The first half is given over 8 hours. The next half is given over 16 hours. But most of the time, once you start the fluid, you will look at the urine output and decide. But for some reason, if you're not able to check the urine output, then you'll follow this formula itself and continue for 24 hours. This is for any patient who is not in shock, no shock. That means systolic blood pressure is more than 90. If less than 90, then fluid boluses you'll be giving. Once his blood pressure is improved, then you will start the fluid infusion according to the Parkland's formula. Now we'll be entering into the recall questions, what we'll be having. Anyone else have any questions before we enter into the recall questions? Okay, there seems to be none, so we'll proceed ahead with the recall questions. The first question what we are having is a 19 years old female was involved in a road traffic accident and a head-on collision with a four-wheeler. Paramedics at the scene immobilized the C-spine and brought her to the emergency department. The patient is complaining of difficulty in breathing. Which one of the following is an indication for early intubation and mechanical ventilation in this patient? Which one really indicates that you need to do an early intubation? They are asking here. Let us break down each one of the following coming from V's. V's is always suggest you have something wrong in the lungs. Okay, you might treat an V's with just giving a nebulizations. So it is not an absolute indication to go ahead. Gurgling sound is mainly because of accumulation of the fluid in the mouth. So suctioning should usually improve this, will rarely require for you to go ahead with an definite airway. Inspiratory stridor. Stridor is because of the narrowing of the airway. Anything which causes narrowing of the airway, stridor is developed. So narrowing of the airway can be because of a foreign body. Most of the time it is because of the foreign body or development of the swelling. So that itself is not an indication. If a foreign body is present, you can easily remove it off. So that is not an indication. Low SpO2 level, saturations, you can supplement an oxygen saturation and increase it. But in a traumatic setup, if it is the hardness of voice, if the patient is having, then what are we thinking of? Then we are thinking of a laryngeal fracture, which requires a prophylactic intubation. For that reason, anyone who has an hoarse voice in and setup of an trauma, you need to think of laryngeal fracture and do an prophylactic intubation and an early intubation. 3 years old boy was brought to the emergency department with accidental spillage of hot water over the right upper limb. The baby is crying continuously due to the pain. The nurse has administered intranasal Dymorph. On examination, second-degree burns are noted over the upper limb. Parents irrigated at home for 10 minutes. What is the most appropriate immediate action they are asking? What we do usually stepwise manner, we usually remove any jewelries are there and plus we'll remove the clothing. Then we will irrigate. How long do we irrigate for? We irrigate for 20 minutes. Here irrigation is done only for 10 minutes. So you need to irrigate for another 10 minutes here. So the right answer here is the fourth one, not the fifth one, because already the painkiller intranasal dimorph is given. That is the best painkiller, which is 10 times more potent than the morphine has already been administered. So you are not giving more morphine to this, not required. The next step is to irrigate for 10, irrigate total of 20 minutes to additional 10 minutes needs to be irrigated for. An 18 years old male has fallen from the bike. He presented the minors to the emergency department with complaints of right shoulder pain and swallowing problems. He has abrasions over the right shoulder and the chest. His vital parameters are grossly within the normal limits. What is the next most appropriate management step? What you will do in this circumstance, what they are asking. What you can see is there is a right shoulder pain. There is a swallowing problem. Okay. And abrasions are seen over the chest. So in these circumstances, you need to do a primary survey. This looks like an polytrauma. A primary survey is a must. What you'll be looking out for in the primary survey, you will be looking out for any life-threatening injuries are present and dealing with it. Once you are finished with the life-threatening injuries, then you will be doing other parameters. Though the vital parameters are stable, doesn't rule out life-threatening injuries are present. For that reason, primary survey is a must. You will be this the first one what you'll be doing in this patient. A 67 years old male was involved in a road traffic accident. He presented to the emergency department with complaints of left-sided chest pain with breathing difficulty. On primary survey, the airway is patent. On assessment of the breathing, revealed reduced air entry on the right side, okay, of the chest. We will consider this as a left side. Okay, if you consider this as the right and this is left, so the findings here on the left side. So consider it as a left side. And the mobile chest X-ray was requested, which is shown as below. Which one of the following is contraindicated in this patient? So which one is contraindicated this patient they are asking? Recitative endovascular balloon occlusion of the aorta. What it does, it occludes the aorta. Okay, once you occlude the aorta, then if the bleeding is intrathoracic, it is contraindicated because it will cause increased bleeding in the intrathoracic space. Increased bleeding because it is obstructed here, the entire blood will accumulate and the pressure will increase and increased bleeding will occur. Are we suspecting an intrathoracic bleed here? Yes, we are suspecting because there is an left-sided effusion. Along with the left-sided effusion, you can see mediastinal dilation is present. For this region, you are expecting there might be an intrathoracic bleed. Okay, for that reason, REBOA, that is recitative endovascular balloon occlusion of the aorta, is contraindicated in this circumstance. And whenever you're seeing an pleural effusion in a patient of a trauma, you need to always consider this as an hemothorax. The fluid, what you're seeing here, is the blood, what you need to consider. Let us see rest of the options. ET tube might be required if the patient is respiratory compromised and go into respiratory arrest, might be required because just is involved here. Stenotomy, yes, might be required if a major artery is bleeding, you want to rectify it. If you want to confirm whether it is an aortic disruption which is present, transesophageal echo might be helpful in the circumstances. It's just an hemothorax, then chest drain will be required in these patients. So all this might be required in this patient, but Reboa is not required. That's why the right answer is Reboa, the fourth one. Sorry, the fifth one. The right answer is Reboa. A 67 years old male has slipped and fallen down the stairs and sustained injury to the head. He is a known case of rheumatoid arthritis on primary survey. No life-threatening injuries are seen. You get an CT scan head done, which shows an intracranial bleed with midline shift, which is usually suggestive of a raised intracranial pressure because midline shift is present. What is the immediate step in your management? What we do in the emergency department is just prevent the secondary brain injury. To prevent the secondary brain injury, the step one to prevent it is to head and elevate around 15 to 30 degrees head and elevation is the recommended one. So this is the recommended one. Rest of the parameters are also recommended. Normocapnia, yes, recommended. Hyperventilation, nowadays it is not recommended. Previously it was recommended. Now it is not recommended, but it is not in first step. Hypertonic saline or mannitol, you always give it with the advice of neurosurgeons. You will not be giving yourself. The call needs to be taken by neurosurgeons. A 47 years old female was brought to the emergency department by ambulance. The patient was involved in a road traffic accident. On arrival to the ED, the patient's primary survey doesn't reveal any life-threatening injuries and the fast scan is a negative for free fluid. You get NCT polytrauma done, which was reported verbally normal as verbally as normal by the radiologist. You shift the patient to the ward for observation. You get a phone call from the radiologist after a couple of hours saying that there is a grade 2 tear of liver and spleen. What to do in this circumstance? There is an injury to the liver and spleen. So he can start bleeding, though he was stable, he can start bleeding, or he might be slowly oozing and he can become unstable at any point of time. So it is best that you shift this patient back to the resuscitation and involve the surgical registrar as soon as possible. Because inwards, if the patient deteriorates, you may not be able to resuscitate. That's why shifting to the resuscitation should be the ideal thing. Contact the surgical registrar without shifting to the registration is not advised. That's why the first one is wrong. Contact the anesthetic doctor might not be required at all here. Nothing is suggestive of airways compromised. Inform surgical consultant for potential laparotomy. Yes, you will be informing, but first you will be shifting to the resus pay. Inform junior doctor to reassess the patient. No, it is not required. First, get the patient to the resus because you already have the report that there is an injury to the liver and spleen. A 25 years old female was involved in a bar fight. She got punched multiple times in the face. She complains of double vision on looking upwards. On examination, vital parameter seems to be all right. The image of the eye is shown below, below while requesting the patient to look upwards. When you are trying to look upwards, your eyeball moves upwards. This one is not moving upwards. Why? There are multiple punches and there is a bruise here. So what we are suspecting here is orbital floor fracture is there. Along with there is a herniation of inferior rectus muscle. That's why the eyeball remains in the neutral position, doesn't move upwards. Because of this reason, the patient will end up having double vision, also known as diplopia. So this diplopia is because of left-sided inferior rectus muscle entrapment. This inferior muscle entrapment is because of the fracture of the floor of the orbit. A 65 years old male was involved in a road traffic accident and there was a collision with another car while traveling at an approximate speed of 30 kilometers per hour. After the collision, the patient was able to get out of the car. Presently, he complains of a mild midline cervical spine pain. In the emergency environment, the patient is sitting comfortably. Which one of the following is an indication for the immediate C-spine imaging in this patient? This is a very important question. Usually people get confused here. So what is the indication for an immediate C-spine in this? Is the age. Okay, because in what's the first column or the first box we look out for? Anyone whose age is equal to or greater than 65, dangerous mechanism of injury, or any paresthesia of the extremities if present. These are the three things what we'll be initially looking for here. The age is 65 years age group. That's why the option 1 is the correct one. Next one is a 19 years old female present to the ED with an accidental splash of hot water to the face. She complains of a burning sensation on the face. The nurse gave the painkillers a triage. There is no hotness of voice and she denies any breathing difficulty or burn to any other part of the body. An image of the face is shown below. What is the best next step? What we'll do? Facial burns. Whenever you are having facial burns, we need to see which degree or how severe is the burn. Is it the superficial burn? Is it the partial burn? Or is it the full thickness burn? It is the superficial thickness because only redness, what you're seeing, that is the only erythema, what is seeing. It is not basically, sorry, it is not a charred skin, what you're seeing, or you're not seeing any blisters here. So it kinds of rule out the partial and full thickness. Only redness is seen, so it is a superficial burn. Any burns to the face, it is recommended that you involve the burn or you just talk to the burns unit or refer to the burns unit. So the right answer here is to refer to the burns unit. Anesthetic review would have been right answer if it was an third degree burns, that is also known as full thickness burns. A 44 years old male is involved in a road traffic accident. Airway is fine. Breathing seems to be fine. Circulation, he is in shock because of tachycardia, hypotension, CRT is elevated. Fast scan shows free fluid in Morrison's pouch. Pelvic examination normal, but the junior doctor has applied the pelvic binder. Surgeons are requested to shift the patient to the operation theater. When should be the pelvic binder removed? This is a tricky question. When you will remove the pelvic binder? You will remove the pelvic binder once the patient is hemodynamically stable. Though examination-wise, the pelvic might be seem to be stable, you cannot rule out any pelvic fracture. The stability might be because of the pelvic binder what you have put on. For that reason, it is always recommended if you have applied a pelvic binder, keep it till the patient is stable. So leave it until the patient becomes hemodynamically stable. In this question, one more point I would like to add is this is a superficial burn. Whenever you call or refer to the whenever you refer to the burns unit, what they will recommend? They will usually recommend to ask them to apply the paraffin wax. Okay, sorry, paraffin wax, what they will be asking you to apply. When you ask the patient to apply the paraffin wax, you need to always recommend them don't go near the fire. That means do not cook anything, do not smoke. If they go near the fire, paraffin wax can catch the fire and cause severe burns. That needs to be advised before you discharge this patient. Remember that additional point. A gas cylinder blast in a camp resulted in a 30 years old female sustaining injury, severe burn injuries. On examination, he has a circumferential burn over the chest, which is causing restriction of the movement of the chest wall. You plan to do an hysterectomy in the emergency department. What will be the depth of incision? What do you need to remember? This additional point, what I wanted to discuss with the question here. That's why we are discussing here. The additional point, what you need to remember is if there is a full thickness punch and it is a complete circumferential punch, it might be over the limbs, it might be over the chest. Okay. If it is a full circumferential burns, it will hamper either in the limbs, it will hamper the arterial circulation and cause acute limb ischemia. In the chest, it can cause, in chest, it can hamper the breathing. The chest expansion will not expand because it is constricting the expansion that can cause shortness of breath. So to relieve the tension what has developed, what you'll be doing is you'll be doing an incision up to the level of subcutaneous fat. Okay, subcutaneous fat or the subcutaneous tissue, mainly subcutaneous fat, up to that level, up to that deep, you will be incising it. You're not going deeper to the muscle layer. What we usually do, go up to the level of muscle layer, remove the dead muscles, and then compartment syndrome, that is fasciotomy, what we are doing here. Not fasciotomy, it is known as sclerotomy. In sclerotomy, the incision is up to the depth of subcutaneous fat. Incisions, when you're doing it, it should be on two sides. For example, this is the limb. So two sides it should be on one on the medial side, one on the lateral side on the limbs. In chest, you should make and square. Then only the chest will be able to expand. So to what level or to what depth you will be doing it? To the depth, what you're doing it is up to the level of fat tissue. Okay, to fat tissue or subcutaneous tissue, what you'll be doing it. Okay, that's the subcutaneous tissue. Not epidermis will be very superficial. Someone has come in and asking about this chart for children, how to use it. It is a diagram what they would have given. You are just following it and you're doing it. In facial burns, when to intubate, you need to refer to the class. Okay, we have completed. I have spent around 5 to 10 minutes explaining the indication for the burns. You cannot come in between and ask me the questions. A 21 years old male was involved in a fight at a local railway station. He got stabbed in his upper back. The airway is patent, but the patient is in shock. To find out the cause of hemodynamic compromise, you perform a bedside ultrasound scan to check the lungs and the IVC. The image of the same are shown below. What is the most likely cause for the hemodynamic instability? Okay, lung ultrasound, you are doing it. Okay, in lung ultrasound, the first image is given to you. In first image, what you can see here is the seashore sign. Why do I call it as a seashore sign? Because this appears like a water, this appears like a sand. That's why they call it as a seashore sign. Seashore sign is seen in lungs which are normal. All right. So you kind of ruled out an pneumothorax. When you see an seashore sign, you rule out an pneumothorax. Next image is given of an IVC. IVC, they are showing as the diameter of 2.26 centimeters. Anything more than 1.5 centimeters on an ultrasound scan, then you can consider the IVC as distended. So the veins are distended. If the veins are distended, you have two differential diagnoses in an traumatic case. One differential diagnosis is an tension pneumothorax. Another differential diagnosis is an cardiac tamponade. Out of these two differential diagnoses, you can rule out an tension pneumothorax because there is no barcode sign, seashore sign is seen. If you ruled it out, you have a cardiac tamponade as the diagnosis. So what is the most likely cause here? It is the cardiac tamponade. That's how you need to do it. This was an FRCM exam question. A young female was involved in an argument with her husband. She got stabbed in the abdomen by her husband. On examination, tachycardia, hypotension is present, and there is some amount of breathing difficulty. Major hemorrhage protocol is activated. You started with PRBCs and FFPs has been given. The patient continues to have severe abdominal pain with no improvements in blood pressure. The most appropriate step in the management of this patient, what we'll be doing? This patient has two parameters you need to be aware of. Stab injury. Stab injury means it's a penetrating injury. It's a penetrating injury to the abdomen what is present. Along with it, the patient is in shock. Why do I call it is in shock? Because the blood pressure, systolic blood pressure is less than 90. This is an indication for immediate laparotomy. Your aim should always be to stop the bleeding. Here you can stop the bleeding by doing an laparotomy. So you need to involve the surgeons on an immediate basis, get an laparotomy done. What about fast scan? Fast scan, you will not get it or it is not required because it is a penetrating injury. You need not look for free fluid. You can directly refer for laparotomy. If it was a blunt injury, then fast scan would have been the right answer. CT abdomen, you cannot get it done because the patient is unstable. Transfuse more blood products, yes, will be required, but the first step is to stop the bleeding. That is, involve the surgeons and ask them to perform a laparotomy and stop the bleeding. CT polytrauma, again, you cannot get it done if the patient is unstable. A 20 years old male was involved in a bar fight. He sustained multiple blows to the face. He presented to the ED with bruises over the face. No life-threatening injuries were found in the primary survey. X-ray of the facial bones is taken and shown below. What is the most likely diagnosis? We'll have a closer look at the X-ray. This is an occipitomental view, ohm view of 15 degrees. Whenever we have an ohm view of 15 degrees, we need to always suspect an orbital floor fracture. So we look at the thickness. This thickness, if you compare with this thickness is increased, suggesting of an orbital floor fracture. This sign, what you're seeing, is known as teardrop sign. Keeping this both in mind, it is an left orbital floor fracture will be the right answer. A 65 years old male present to the ED with a neurological deficit. On examination, the patient is stable. You are strongly suspecting an anterior cord syndrome. Which one of the following deficit you are likely to see in the patient? Anterior cord syndrome. Anterior cord syndrome, it kind of preserves the dorsal column. Rest of the part is involved, or rest of the part will get affected. Dorsal column, the function or the functionality is to carry the vibration and proprioception. So you need to select an option which doesn't have the vibration and proprioception. This has the vibration, so you can rule it out. Temperature and pain. Yes, this is the right answer because this is carried by a spinothalamic tract, which comes somewhere here and it is involved. Vibration, proprioception, no. Proprioception again here, no. Vibration here, again, no. That's how you can rule out and pick up the second one, which are carried by spinothalamic tract. We have a 44 years old male was involved in a road traffic accident and sustained injury to the lower back. The primary survey shows no life-threatening injuries. In the secondary survey, you are doing a neurological assessment as you suspect an spinal cord injury. Which one of the following statement is correct regarding the neurological deficit? The motor level is the lowest key muscle that has the muscle strength of 6/6. No, that is wrong. Has the muscle strength of 3/6. The sensory level is the most cephalic segment of the spinal cord with a normal sensory function, not cephalic. It is the caudal part which has the normal sensory function. The zone of partial preservation is the area just below the injury level. Yes, this is the correct statement. Sensory level is the most caudal segment of the spinal cord with an abnormal, no, not abnormal, with a normal sensory function. The zone of partial preservation is the area above or below the injury level. No, it is just below the injury level, not above the injury level. So again, it is the wrong one. So the correct one is here. These phrases are taken directly from the ATLS. Okay, from ATLS, I have quoted from where these phrases were taken. It was there in the exam previously. So the right answer here is the third one. It is the phrasing what you need to remember when, what is the motor level, what is the sensory level, what is the zone of partial preservation. These are the three things what you need to be aware of, which I have covered in this question, question number 16. Be remember, add it up in your notes. It is important. The same question has repeated, I think thrice, three times in three different diets it has repeated. So be aware it can repeat again in your exam. A 32 years old had a couple of drinks and was going down the stairs. He missed a step and has fallen down. He complains of pain in the back of the neck. The patient is hemodynamically stable. You get a CT sign done and shown below what's the most likely diagnosis. Most likely diagnosis, it is not the tip or it is not the base. It is completely below the base level, which is involved here. That is the type 3 odontite fracture it is. So the right answer here is the type 3 odontite fracture. C1 fractures are known as Jefferson's fractures. C2 fractures are known as Hangman's fractures. C2 fracture, that is pars interarticularis, should be involved to call it as an Hangman's fracture. This is also a C2, part of a C2 what we are talking about. But this is the odontite process, which is fracture, which is also known as PEC. Today, too much of voice interruption. It cannot be possible because everyone is muted. There cannot be voice interruptions. It is your connection what is you are having the wrong. An 11-month-old baby was playing with his brother. While playing, he fell down from a table and the height of the table was approximately 1 meter. Soon after the fall, the baby was unresponsive for 6 minutes. Parents deny any vomiting. On examination, the baby is hemodynamically stable and note a bruise over the temporal region which is measuring about 4 centimeters. The most appropriate management plan for this patient is what we need to consider in this patient now. Okay, approximately 1 meter. 1 meter is not a dangerous mechanism of injury. It is a 3 meters what we'll be looking at. He has a significant loss of consciousness. Anything more than 5 minutes is taken as significant loss of consciousness. Okay, This is only 4 centimeters, so we can ignore that part also. So you have only significant loss of consciousness, so it requires an observation for 4 hours. In this 4 hours, you will be looking at any further episodes of vomiting, any further episodes of disorientation is present. Then you will go ahead and get an CT scan done. Coming to the bruising, one of you are recommending here. Bruising, if it is 5 centimeters or more than 5 centimeters, that's when you get an immediate CT scan done. Otherwise, it is not an indication. So bruising should be more than 5 centimeters, not equal to also. It is more than 5 centimeters. Sorry. It's more than 5 centimeters and the age less than 1 year. Age was 11 months. Yes, less than 1 year. But the swelling was not, or the bruising or the swelling what was present was not more than 5 centimeters. So it is not an indication. If it was, then you will get an immediate CT scan done. So you are basically you had only one risk factor here. So one risk factor was present. That's why you were observing for 4 hours. In the 4 hours, you'll be looking for GCS, any further episodes of vomiting, any abnormal drowsiness. A 19 years old was hit by a car while crossing the road. Paramedics at the scene gave him some painkillers and brought him to the ED. On examination, the airway is fine. The breathing oxygen is required, and there is some amount of tachypnea. Circulation seems to be fine. Deformity is fine. Chest is shown. What is the next best step? In a traumatic case, whenever you see an pleural effusion, as shown here in the picture, you need to always consider this as an hemothorax. Whenever hemothorax is there, you need to place an ICD. When you are placing an ICD, in a case of an trauma, remember that it is always an open technique what you are using. There's one more technique to place an intercostal drain that is known as Seldingham's technique. Seldingham's technique is not preferred because you cannot insert a large size chest tube. You need a large size test tube in a traumatic case because we always expect there might be some amount of blood what you will be draining. If it is a small size chest tube, you cannot drain the blood. For that reason, open technique is always recommended to place an ICD in a patient who has a trauma. So ICD, to be more precise, use an open technique and use a large size ICD. A 3 years old child has fallen down from a cot, resulting in injury to the head. Worried parents have brought the kid to the ED and requesting you to get the CT head scan done. On the primary survey, no chest injuries were found. Presence of which one of the following is an indication to get a CT scan done within an hour's time? GCS, which is the indication to get it done? GCS less than 15 after 2 hours? Yes, that is an indication. What about GCS less than 15 at the presentation? Here the age is more than 1 year. It is 3 years age group. So the GCS should have been less than 14 to get it within 1 hour's time. Loss of consciousness? No, doesn't come. One episode of vomiting? No, doesn't come. Dangerous mechanism also doesn't come. It is a combination of the risk factors what you will be seeing. If three, that is more than one risk factor was present in the same patient with the LOC being more than 5 minutes, at that point of time, you would have got it within 1 hour. Here, out of the answers what they are given, it is the only first one which is the correct one. A 39 years old female rescued her dog from an house fire due to an explosion. On examination, she is noted a hoarse voice and drooling, and there is a decreased air entry in the right chest, and then there is a bleeding gush over the right thigh. She has burns on her arms and face. There is an obvious deformity to her wrist. Observations have tachycardia, tachypnea, saturation on the lower side. Blood pressure is fine. GCS is on the lower side. Her abdomen is tender in the right upper quadrant, but there is no guarding. What is the immediate priority? Immediate priority for us, always we go according to airway, breathing, circulation, deformity. Airway, is something wrong in the airway? Yes. Hoarseness of voice and drooling is present, which is an indication for prophylactic intubation. That's why you need to go ahead and involve the anesthetic so that you can, immediate priority here, anesthetic review for prophylactic intubation. So get the answer 4 will be the right answer here. A 24 years old was involved in a road traffic accident. Paramedics have brought the patient to the ED. On assessment, the patient had low GCS and hence intubated. After some time, vital parameters are as follows. There is bradycardia, there is hypertension. Along with it, the saturations on the mechanical ventilator in 99. So that these two parameters are fine. What is the most appropriate next step? What is the bradycardia along with high blood pressure is suggestive of? This is known as Cushing's reflex. Cushing's reflex is a late sign of an raised ICP. Due to raised ICP, you see an Cushing's reflex, which is a late sign. So there is an head injury. What we can do in this circumstance? We can prevent an secondary brain injury. How do you do prevent the secondary brain injury? The first step is always to raise the head end by 30 degrees. So the right answer here is the third one. A 9-year-old boy was hit by a car while he was bicycling. He sustained multiple injuries and the parents immediately brought the child to the ED. On assessment, the child is talking and there is reduced air entry and dullness on percussion on the right side of the chest. You're strongly suspecting pneumothorax. Which one of the following is the best initial investigation for this chest child? Which one is more sensitive here? Is it the chest X-ray or is it the fast scan? Or is it the ultrasound? Basically, we are asking extended fast scan is nothing but the ultrasound. Ultrasound is more sensitive to pick up a pneumothorax or an hemothorax or the lung pathology in an trauma case compared to that of an X-ray. So ultrasound scan is the best one. So extended fast scan is the right answer here. CT scan is not the bedside investigation. You need to shift it. Bedside X-ray is a good one, but it's not as sensitive as an ultrasound. Radiological department chest X-ray is not recommended. You cannot shift this patient. At the same time, CT also cannot be shifted out for this patient. They are asking and bedside. Best initial investigation they are asking. Initial is use and fast scan because this patient seems to be unstable because he is having reduced air entry and dullness on percussion. Stabilize, then you shift it. A 58 years old male has slipped and fallen down the stairs. He sustained an injury to the head. On assessment, the vital parameter seems to be fine. GCS is 14. You notice a large lacerated wound over the scalp. The patient is shifted to the CT room for a CT head. Soon after returning from the CT room, the GCS has fallen down to 8 with rapid breathing. What is the most appropriate next step in management of this patient? Again, we'll be going according to airway, breathing, circulation, deformity, and exposure. In airway, is there any indication to get an advanced airway done? Yes, GCS is on the lower side. Any GCS less than 9 is an indication. It is 8 less than 9. So you need to intubate and ventilate this patient. So the right answer here is the first one, intubate and ventilate. A young male was brought to ED in an ambulance. History of being stabbed between the scalps a few hours back. On examination, the patient is humanly stable, obeying commands. On neurological assessment, you find ipsilateral loss of vibration touch sensation with contralateral loss of pain and temperature sensation. What is the most likely diagnosis? Ipsilateral loss of pain and temperature, that means the dorsal column, what they are talking about. Okay, in dorsal column is on the same side. Pain and temperature, that is spinothalamic tract, which crosses in the thalamic tract, which crosses in the spinal cord itself. That's why it is contralateral. That means one half of the spinal cord is injured, which is seen in Brown-Sequard syndrome. Most common mechanism is stab or and gunshot injury. So the right answer here is Brown-Sequard syndrome. Prognosis is excellent in this. Prognosis is poor in Antioch syndrome. A 13 years old male kid was playing with his neighbors, has fallen down with a face resulting in avulsion of the tooth. It has been 1 hour since the incident. Parents have brought the kid to the emergency department along with his avulsed tooth. On examination, the patient is medically stable. The nurse administers the painkiller. You notice debris are on the wound. The most appropriate plan for the kid is they're already in the emergency department, so you do not want to transport it. Don't clean and reimplant. No, you will gently clean the tooth, okay, and reimplant. Don't clean and place it in the buccal floor. No, you're not transporting. That's why it is not the right answer. So you'll clean the tooth with the saline, gently clean the tooth with the saline, and you'll be reimplanting. Usually the questions which I receive here is, it is been 1 hour. So it is not more than 1 hour. So approximately 1 hour they are saying, still you can implant. If they clearly says it's been more than 1 hour, at that point of time, you will not implant it because failure rates are on the higher side, infection rates on the higher side. Here, you can implant it. After implantation, you need to secure it and refer to the dentist. A 68 years old female was involved in a road traffic accident. At the scene, the patient has been cleared of any life-threatening injuries by the paramedics. Brought to the ED. On arrival to the ED, the patient complains of chest pain and vital parameters are within normal limits. You get a CT chest done, which has been reported as lung contusion. What is the most common complication associated with the lung contusion? Lung contusion patients, we always admit in level 2 care. Why do we admit in level 2 care? Because they are prone for ARDS. For that reason, we admit them in level 2 care. So the right answer is ARDS. The same question has repeated in September 2025 died. Sorry, 2024 died. It was repeated in September 2024 died. A 21 years old male was involved in an bar fight, stabbed in the chest with a broken glass. On arrival at the ED, the patient complained of right chest pain. On examination, the patient vital parameters within normal limits. Notice an open wound over the right chest and bubbling. This is the important term. Bubbling is present. You immediately apply the dressing. The nurse has gained the IV access and administered analgesia. Soon after, you notice that the patient is hypotensive with an low saturation levels, the most likely explanation for the sudden deterioration in the patient's condition. Dressing, they are saying what we supposed to do. We supposed to apply a three-way dressing. One side should be a non-occlusive, or it shouldn't be occluded. Only the three-side dressing needs to be done. What happens if we do a four-side dressing? Four-side dressing, there will be retention of the air resulting in development of the tension. Most likely it is a four-way dressing what you have done instead of three-way dressing, resulting in tension pneumothorax. That is the explanation of sudden deterioration of this patient. So the right answer is the fourth one. A 79 years old male comes to the ED with complaints of neck pain. He's been using a cervical collar. On examination, the patient is hemodynamically stable. Neurological assessment reveals upper limb power of 3 by 5, lower limb power of 4 by 5. So upper limb weakness is much greater than the lower limb. You get an MRI scan done for the cervical spine was done. What is the most likely diagnosis? Whenever the upper limb weakness is more than the lower limb and they are asking about the spine, you need to think of central cord syndrome, and it is commonly seen in an elderly person. Everything fits in, so the right answer is central cord syndrome. A 67 years old female was slipped and fallen down, and she sustained an injury to the head. Her husband has called the ambulance. On arrival at the ED, the patient complains of headache. The nurse secures the IV line and administers the analgesia. A lacerated wound is noted over the scalp. No obvious injuries were noted. No other obvious injuries were noted. Which of the following is not an indication to get an CT scan done within an hour's time? Low GCS, yes. A GCS of less than or equal to 12 in the ED or less than 15 after 2 hours is an indication. Active seizures or any seizures after trauma. Signs of base of skull fracture, yes. More than one episode of vomiting, yes. Dangerous mechanism of injury, not an indication to get NCT scan done within an hour's time. So this is the right answer here. So dangerous mechanism of injury doesn't come in this column. That's why that is the right answer. A 19 years old male was involved in low-speed road traffic accident. Paramedics at the scene has ruled out any life-threatening injuries. As the patient was complaining of neck pain, they did a 3-point immobilization of the cervical spine and transferred to the ED. The triage nurse has requested you to assess the cervical spine to see the need for imaging. Which one of the following is not an low-risk factor for Canadian C-spine rule? Not an low-risk factor. Simple rare motor vehicle collision, yes. Ambulatory at any time, yes. Delayed onset of neck pain, yes. Absence of midline C-spine tenderness, yes. These are all known as low risk factors, which is seen in second column, low risk factors. Ability to rotate laterally. If any low risk factors are present, then you will check. This is not a low risk factor. So the right answer here is the fifth one. A 50 years old male was involved in an high-speed road traffic accident. He sustained multiple injuries, was brought to the ED in an ambulance. On arrival to the ED, the patient is connected to the high-flow oxygen. Patient's vital parameters are as follows. There is tachycardia is present and large amount of oxygen is required to maintain. That is, high-flow oxygen is required to maintain saturation of 80 only. It is not increasing. This significant amount of tachypnea also. X-ray has been given. What is the most appropriate next step in the management of the patient? Let us closely analyze. This green thing is nothing there. The X-ray looks absolutely fine for me. The costophrenic angles are fine. The apex, I cannot see any pneumothorax at all. Bronchovascular markings are seen up to the level of the chest wall. So X-ray trauma-wise, mediastinum also looks fine. There is no looking cardiomegaly is there to think of an cardiac tamponade. So I had ruled out an cardiac tamponade and I've ruled out any mediastinal swelling suggestive of an aortic disruptions. I've ruled out a pneumothorax. I ruled out a hemothorax. So unlikely the pathology is in the chest, but still the saturations are low on high flow oxygen. That means something is wrong in the upper airway. If something is wrong in the upper airway causing low saturations, what you will do? You will secure the airway. Definitely airway is required. So intubation is the right answer here. A 23 years old female was involved in a high-speed car accident. In the emergency department, the patient is not responding, but signs of life are present. The nurse immediately connected to the cardiac monitor. The monitor shows tachycardia, hypotension, saturations on the lower side, very low, and tachypnea is present. Picture of the face is shown below. What is the next step, immediate step in the management? So you're assessing the airway, what you will be doing. What you'll be doing is open the mouth, do suctioning while you're stabilizing. That is manual stabilization of the C-spine is done. So this is the right answer here. Look, listen, feel. Okay, that is not given. Look, listen, feel. But saturations on the lower side, something is wrong. You are suspecting in the airway because of the external injuries what are present. That's why you'll open the mouth, do suctioning. Then you will maintain the spine stabilization using a manual inline stabilization, not 3-point immobilization. This is wrong. You'll do manual inline stabilization. So the right answer here is the second one. Doing an head tilt maneuver with oxygen will open the airway, will not open the oral cavity. You need to open the oral cavity by just putting your index finger and the thumb and you open the oral cavity. A 33 years old male has fallen down his motorcycle. The patient has was wearing a helmet, sorry. The vital parameters seems to be fine. GCS is on the lower side. The patient was intubated and shifted to the CT room to get a CT image done. CT image is shown below. What is the most likely diagnosis? The CT image shows it is in crescent shaped. Crescent shaped means STH. So the right answer here is STH. If it was a lens shaped, then you are thinking of an EDH. Subarachnoid hemorrhage, it comes somewhere in between, and frog pattern, what we'll be seeing for subarachnoid hemorrhage. A young male was involved in a road traffic accident, head-on collision between two four-wheelers. He sustained injury to the face as shown in the picture. So bad facial injury is present. On arrival at the emergency department, one of the nurses secures the IV line and the junior doctor connects to the cardiac monitor. The junior doctor requests your help in management of this patient. The best initial step in management of this patient is what you will do for this patient. Remember, you need to go in a sequential manner. The first step always is manual inline stabilization of the C-spine. The second step is to manage the airway and whatever intervention is required for the airway. The third step is 3-point immobilization. Okay, whenever in this kind of scenario, if they have not mentioned manual C-spine stabilization, if they have just mentioned a C-spine stabilization, you can consider they are telling you or they are talking about manual C-spine immobilization. Do not consider 3-point immobilization unless they specifically mention and 3-point immobilization. So I have in multiple versions of similar questions which we'll be discussing in coming up slides. So here what we'll be doing, the first thing is manual inline stabilization of the C-spine. So the right answer here is the manual inline. After this has been done, then you'll assess the airway. Bad facial asymmetry is present, bad injury is present, airway can compromise at any point of time. So you need to do a prophylactic intubation. A 46 years old female had been to a party with her friends. She ended up in a fight with another group of friends. She sustained multiple blows to the face. She denies any other injuries or loss of consciousness. On examination, the patient is immunologically stable. You get an facial X-ray done as shown below. What is the most likely diagnosis? Again, punches. You have an occipital mental view of 15 degrees. Orbital floor fracture we are suspecting. We are looking at the thickness. Thickness is increased here. So left orbital floor fracture. So diagnosis is easy. It is a left orbital floor fracture. A 9 years old child was brought to the ED by her mother. Today morning, he had been to karate class where he accidentally sustained injury to the neck while practicing. He complains of pain in the back of the neck. He denies any other injury. The triad nurse has given analgesia, but he continues to have pain. A cervical C-spine is done, which is reported as normal. The most appropriate next step for the management of this patient is giving more painkiller. You already given. Why you want to give more painkiller? Discharge with painkillers. Can we discharge? Reassure and advise to follow up with the GP. That is discharge and follow up with GP. Can we do it? Repeat the C-spine X-rays for after a couple of days. Is this the right answer? No, no, and no. The right answer is admit. Why do you want to admit this patient? Because most of the time there might not be a fracture, but there might be an underlying C-spine fracture might be present. That is spinal fracture might be present. Sorry, spinal injury might be present without an cervical spine fracture. It is commonly seen in children because of the increased flexibility of the vertebrae. So this patient requires an MRI scan done to rule out an spinal cord injury without an radiological abnormality. So you admit for further evaluation. That is nothing but to get an MRI scan done to rule out an spinal cord injury without radiological abnormality. A 55 years old male was involved in a low speed road traffic accident. Soon after the incident, the patient has pain in the back of the neck. The ED, the patient continues to have pain. You inquire about the allergies and the prescribed painkillers. You get an X-ray done as shown in the picture. What's the most likely diagnosis? So X-ray is given. They're asking about the diagnosis. Whenever they give this kind of X-ray, either C1 fracture will be there or it will be a pec fracture. Pec fracture seems to be fine here. This is not an fracture line. This is an artifact which extends from here. That's why that is not a fracture. Next thing you'll be looking, it might be an atlas fracture, C1 fracture, also known as Jefferson's fracture. Lateral borders, lateral borders, lateral borders, lateral borders. Are they in alignment? No, they are not in alignment. So it is an C1 fracture, which is also known as Jefferson's fracture. C1 fracture is like a polo chocolate. If it breaks one side, it breaks another side and it gets separated. That's why you see in this manner, the alignment is lost. A paramedic has called with the 2 minutes estimated time of arrival. A 22 years old female was involved in a road traffic accident, having low oxygen saturation. On arrival to the ED, you receive the patient in resuscitation bay and request the nurse to connect to the cardiac monitor and started on high flow oxygen. A bedside lung ultrasound scan shows the image as shown below. What is the most likely diagnosis? What does the image is suggestive of? It looks like an barcode. Barcode in M mode is suggestive of an pneumothorax. So the treatment for this will depend whether the patient is in tension or not in tension. Not in tension means hemodynamically stable, then you place an ICD. In tension, that is tension pneumothorax, you need to decompress either with finger thoracotomy or needle thoracotomy. Preferred one is finger thoracotomy. A 20 years old female had been to a coffee shop along with a boyfriend. While having a hot cup of coffee, she accidentally spilled over the right forearm. She complains of severe pain over the forearm. You have administered the analgesia. What is the most appropriate next step? Is basically wash. You need to wash for 20 minutes. You need to wash the wound. Before this is remove the clothing and jewelry. We are assuming they have already done it. They are not given in the option. That's why we are assuming it. And we are choosing the option with a running water, is a tap water. You need to irrigate for 20 minutes. A young patient has fallen down the first floor of an under construction building and sustained multiple injuries. Entered to the emergency department, paramedics intubated the patient as the airway was compromised. You receive the patient in resuscitation bay and there is tachycardia. Rest of the parameters seem to be fine. Patient is already on the mechanical ventilator. You notice an sucking wound over the right side of the chest. The best next step in management of this patient. Sucking wound is present. So you're thinking of open pneumothorax. Open pneumothorax, the first step is three-way dressing. So three-way dressing is the right answer here. You join an ongoing resuscitation of a polytrauma patient as a team leader. The patient has been intubated by anesthetic register connected to the mechanical ventilator. No obvious injuries and abnormalities were noted over the chest. Injuries were noted over the abdomen, pelvis, and obvious deformity is noted over the thigh with swelling. There is tachycardia, there is hypotension is present. The most appropriate next step in management of this patient. So circulation is compromised because there is low blood pressure and high heart rate. First step is to stop the source of bleeding. Where is the source of bleeding in this patient? There is obvious deformity of the left thigh. So there is a fracture. If we are suspecting a fracture, you need to place a splint. So that is the first step. So apply the splint to the deformed leg. Fluid restoration or restoration with the fluids and the blood products comes after. First thing you need to always think of is to stop the source of bleeding. That is the first step in the circulation. A child weighing 20 kgs was brought to the emergency department in an ambulance. A fire broke out in the house due to a fault in the gas piping. The kid has a sustained partial thickness burns over the entire right lower limb. Entire right lower limb in an pediatric age group is considered 14%. And he's weighing 20 kgs. Heart rate, there is some amount of tachycardia. Otherwise, it's completely stable. This patient is. So we will start giving fluids according to the modified Parkland's formula, which is 3 into weight into total body surface area involved. So 3 into 20 into 14. So approximately it will come around 840 if I'm not wrong. You can calculate and see 840 what I'm expecting here. Because 3 to 60, so 6 multiplied by this should be 840. So 840, half of this is given over 8 hours. Next half is given over 16 hours. So right answer will be the third one where 850 is there. Half is given in 8 hours followed by another half is given over 16 hours. A 21 years old was involved in a road traffic accident. There was a collision between two four-wheelers. He sustained an injury to the upper back. There is no obvious injury, no other obvious injury seen. In complaints of pain in the upper back, UC and bradycardia, low heart rate, hypotension is seen. Requiring some amount of oxygen is there. Rest of the parameters seem to be fine. Slightly low GCS is present for this patient. Shock. Most commonest shock in a trauma case is an hemorrhagic shock. In hemorrhagic shock, usually what is the physiological response? There is a there's tachycardia along with low blood pressure. There is no tachycardia, but bradycardia, low heart rate is there or marginally low heart rate is there. With a low heart rate and low blood pressure, you need to think of a neurogenic shock. What is the pathophysiology of a neurogenic shock? There is loss of sympathetic tone, which will result in bradycardia and vasodilatation. Bradycardia and vasodilatation. A 24 years old female has fallen down from a balcony while taking a selfie. She has sustained an injury to the head on arrival to the emergency department. The patient has a low GCS, hence intubated. The patient is been shifted to the CT scan for a CT head. Soon after arrival from the CT room, vital parameters are shown here. The patient is bradycardic along with high blood pressure. CT scan is reported as extradural hemorrhage. So this is suggestive of an Cushing's reflex here because of raised ICP. So secondary brain injury needs to be prevented by first step is elevation of the head end by 30 degrees. That is the method what you use it or the first step what you use it to prevent the secondary brain injury. A 29 years old was involved in a fight. He got stabbed in the chest just below the right nipple. The patient is being connected to the high flow oxygen. There is no engorged neck veins are seen. Vital parameters show there is some amount of tachycardia, hypotension is present. You gain an IV access. What is the most appropriate next step in management of this patient? So what do you think has happened here? One of you has mentioned renal decompression. Anyone? Any other answers? Another one have you mentioned as in pericardiocentesis. So let us break down this and see. So needle decompression is done for tension pneumothorax. Pericardiocentesis is done for cardiac tamponade. Okay. No engorged neck veins are seen is suggestive of what? That means there is no tension pneumothorax, no cardiac tamponade. Can be ruled out. Both of these parameters have been ruled out. The injuries is sustained to the chest, which can cause hypotension. Which can cause hypotension other than this? Bleed. Bleed is known as hemothorax. So this patient most likely has an hemothorax in the chest. That's why there is an tachycardia, hypotension with no engorged neck veins. No engorged neck veins are seen in hemothorax. So this is an hemothorax. For hemothorax, what we do, we placed an ICD. So the right answer here is to place an ICD. The next best step is to place an ICD. Later on, the patient will require NCTVS surgeon reference. That is a later stage and might require NCT scan also later once the patient is stabilized. So the right answer is the third one. CTVS surgeon is the not next step. Next step is to place the ICD. CTVS surgeons will be involved later step. They may not even operate. They might just conservatively manage this patient. If it is continuous, that is massive hemothorax is present, they might operate on the patient. A triad nurse requests you to assess the cervical spine of a 60 years old male who was involved in a low intensity road traffic accident. On the way to the ED, he started having pain in the back of the neck. He denies any paresthesia in the limbs. On examination, the patient is hemodynamically stable. You note midline cervical spine tenderness. What is the next best step? What is very important here? What you need to, are there any first high risk factors? What you need to look out for? The first column is known as high risk factors. Are there any high risk factors? Age, dangerous mechanism, paresthesia. Age is 60, not 65. So no, it is not required. Next one is no, denies any paresthesia in the lower limbs. Yes. Is it an dangerous mechanism of injury? He says low intensity road traffic accident. So you ruled out all the symptoms of this. Any one of this following is present. Is there any one of this following is present? That's what you need to look out for. Uh, Low intensity road traffic accident is present. Yes. Along with it, there is, and he started having pain in back of the neck. He started having pain in the back of the neck on arrival to the ED. So that is a delayed onset of pain. So delayed onset of pain is a low risk factor. If any one of this, only one low risk factor is present, delayed onset of the pain is one of the low risk factors here. Delayed onset of the pain, yes, this is one of the low risk factors. Simple ray water motor collision, yes, low intensity injury is present here. Two low risk factors are present. Midline cervical spine tenderness is also present. Doesn't matter. Midline cervical spine present or not. I have one low risk factor, at least one low risk factor. Yes, present. Then you'll directly go ahead and check for the lateral rotation. So the right answer here is to check for the lateral rotation because at least one low risk factor is present. The nurse in charge requests you to assess the patient whom they have just received in the resuscitation bay. A 51 years old male was involved in a road traffic accident. The nurse immediately connected to the patient to the monitor and she's trying to gain an IV access. You start assessing the patient's airway. Which one of the following is not a sign of upper airway obstruction? Stridor, yes. Grunting, yes. Hoarseness, yes. Gurgling, yes. Wheezing, no. Wheezing is not a sign of upper airway obstruction. A 71 years old male was involved in a road traffic accident. He is brought to the ED in an ambulance. Vital parameters shows there is tachycardia, tachypnea, and hypotension, and requiring high flow oxygen just to maintain saturation of 87%. Neck vessels are dilated, heart sounds are muffled. What additional likely finding on the examination? Sorry, heart sounds are heard, not muffled. Heart sounds are heard. What additional finding on the examination of the chest is expected? So what you are having? You are having an hypotension. Yes. Neck vessels are distended. Yes. With distended neck vessels and hypotension, what are we thinking about? We're thinking about tension pneumothorax. Tension pneumothorax is the first thing what we are thinking about. If you're thinking about a tension pneumothorax, what is the first sign what we'll be looking out on examination? Let us see each one of the following. Decreased breath sounds opposite to the lesion. No, towards the lesion, you'll be having a decreased breath sound. Hyperresonance and percussion. Yes, this is the right answer because this is the first finding what you'll be having in tension pneumothorax. Stony dullness on percussion. No, dullness is seen usually in an hemothorax, not an hemothorax, not in an tension pneumothorax. Trachea deviated towards the lesion. No, trachea is deviated opposite to the lesion, not towards, opposite. Bilateral decreased breath sounds. No, breath sounds are decreased only towards the lesion. So the right answer is the fourth one. And remember, the earliest sign to appear is the hyperresonance on percussion. A 34 years old male was involved in a fight. He was being stabbed in his back. He is brought to the emergency department in an ambulance. On examination, the airway is patent, high flow oxygen is connected. The patient is immediately stable. You are suspecting a Brown-Sequard syndrome. Which one of the following do you accept to see it? Ipsilateral loss of temperature. Temperature loss is contralateral loss, not ipsilateral. Loss of pain, which is contralateral. Yes, that is true. Pain and temperature are contralateral. Vibration and proprioception are ipsilateral, not contralateral. Loss of pain is contralateral. Sorry, loss of pain is contralateral. So keeping all this in mind, the second one is the right one. How do you need to remember is spinothalamic tract is contralateral, which carries two functionalities of spinothalamic tract, that is pain and temperature. Dorsal column, which carries two functionality, dorsal column basically carries is proprioception and vibration sensation. Proprioception and vibration sensation are the same side, that is known as ipsilateral. Remember this, very important. They test frequently on spinal cord syndromes. A 23 years old female presented to the ED with pain just below the right eye. She gives a history of being involved in a fight resulting in multiple punches to the face. The primary survey doesn't reveal any life-threatening injuries. You get an X-ray done which is suggestive of an orbital blow fracture. Which one of the following is the complication suspect in this patient? Orbital blow fracture. There are the two complications which can happen. That is herniation of the inferior rectus resulting in diplopia on upward gaze. Another thing is there might be an involvement of which now anyone remembers? Infraorbital nerve. Involvement of infraorbital nerve can result in loss of sensation. So loss of sensation is around the nasal region. So this is the right answer here. Loss of sensation around the nasal region. A middle-aged female present with the ED, she complains of an electrical shock to the right hand while she was using a grinder in the kitchen. She denies any loss of consciousness or any other injuries. On examination, the patient is stable. Entry and exit wounds are present over the right hand. You plan to discharge. Before discharging, what is the investigation you should do? Always get an ECG done because the electricity can interfere with the electricity of your, that means the electrical gradients and the vectors can get affects your heart and can lead to arrhythmias. For that reason, you need to get an ECG. If the ECG shows any abnormality which is new, then you will go ahead and admit this patient for observation for 24 hours. That's why you need to always get an ECG done. A 39-year-old male was brought to the ED with an alleged history of fall from an height. He sustained injuries to the upper back. Examination shows bradycardia, hypotension. What is the pathophysiology of the shock? Again, we know we are already dealt this kind of. So bradycardia and low blood pressure is suggestive of a neurogenic shock. Neurogenic shock, there will be low sympathetic tone, which will cause vasodilatation. So loss of vasomotor activity. Can it be increased vagal tone? Yes, increased vagal tone is also seen in neurogenic shock. Okay, but they're asking pathophysiology of shock, that is low blood pressure. Low blood pressure is mainly because of vasodilatation, because of loss of vasomotor activity, it causes vasodilatation. So they are asking pathophysiology of the shock. They're not asking pathophysiology of the bradycardia, what is seen in this patient. Bradycardia pathophysiology is because of increased vagal tone. Okay, that's why we prefer choosing loss of vasomotor activity as the right answer here. A young adult involved in a road traffic accident sustained a head injury. On examination, airway is connected to high flow oxygen, breathing seems to be fine. Circulation, this is tachycardia, slightly on the higher side blood pressure. GCS is on the lower side, that is less than 9, which will be alarming, requires an intubation. What is the next step in management of this patient? GCS low, airway is the first thing which comes in your mind. Intubate the patient. A 55-year-old female comes to the ED with an history of road traffic accident, sustained injury to the chest. On examination, the airway is patent. No life-threatening injuries are seen. Assessment of the breathing, circulation, and disability. A bedside X-ray is taken and shown below. What is the most likely management plan for this patient? What are we seeing on an X-ray here? What we are having? Do we see any abnormalities here at all on the X-ray? Anyone? There is a rib fracture, what you can see here. There is a rib fracture, what you can see here. So there are multiple rib fractures, what you can see, at least 2 rib fractures, what I was able to pick it up. Whenever there is an rib fractures, what we do, we admit this patient. Why do we admit this patient? Because there are multiple rib fractures, this patient requires good analgesia. If they do not receive good analgesia, the chest expansion will be hampered. Eventually, infection will deal with. So, analgesia and for physiotherapy, you need to admit this patient if there is more than one rib involved or even one rib where the pain is severe. Mainly because you will admit this patients and give good pain management. The best pain management is to give an intercostal nerve block. This this question had repeated in September 24, okay, 2024. A 23-year-old male involved in a road traffic accident sustained injuries. On examination, the airway is patent, connected to the high flow oxygen. Vital parameters as mentioned. There is an hypotension and tachycardia. The pelvic X-ray is taken and shown below. What's the best next step? Pelvic X-ray shows what? It shows an open book fracture. The treatment for open book fracture is pelvic binder. So which one has a pelvic binder here? Fourth one. So fourth one is the right answer. A 26-year-old male had been to a bar along with the friends to celebrate his birthday. After a few drinks, he ended up in a fight which resulted in multiple injuries on the face. On examination, the primary survey does not reveal any life-threatening injuries. He complains of double vision on seeing upwards. What's the most probable cause for double vision? Is basically entrapment of which extraocular muscle they are asking. It is the inferior rectus muscle. A 32 years old male was involved in a road traffic accident. Paramedics found him unresponsive and there was no sign of life. CPR was started by paramedics. On arrival to the ED, the patient continues to be in cardiac arrest. CPR is continued and adrenaline infusion is started. You get an EFAST scan done. The image is shown below. What's the most likely diagnosis or cause for the cardiac arrest? Here, what you can see here is there is a free fluid around the heart. What view are we seeing? This is an parasternal short axis view what we are having, which we have learned in the cardiology chapter. So around the heart, if you see in fluid, that is suggestive by the black color what is present here. In an traumatic case, you need to always suspect to be an tamponade. So it is a pericardial tamponade, also known as cardiac tamponade. This question was tested in September 24. A 35 years old male came to the emergency department with tooth pain. Tooth extraction was done a couple of days back. On further questioning, the patient says that the procedure took a long time. On examination, the tooth socket, there are no clots or bleeding and vital signs are within normal limits. What is the next best step in the management? Irrigate with normal saline is the next step. After irrigation, you will prescribe them the oral antibiotics and plus painkillers, then ask them to follow up with dentist. So this is the sequence of order. So first step is to remove any clots, if at all, if present, usually will not be there. So this will be the first step. This will be the second step. This will be the third step. A young male was involved in a road traffic accident, brought to the emergency department by paramedics with ongoing resuscitation. Paramedics are recommended intubation on an open wound with air entry. Air entering the wound was noted on the right side. Vital parameters have been given here. Bedside, the chest X-ray is as shown below. What is the next best step? What is the next best step in this patient? Is this patient stable or unstable? It is unstable. Why do I call it as an unstable patient? There is tachycardia, hypotension, mainly because of hypotension. I'm calling it as an unstable. What kind open wound is present? Air entering into the wound are noted, which is suggestive of an open pneumothorax. So it is an open pneumothorax what the patient is having, which is unstable. Any pneumothorax which is unstable is considered as an tension pneumothorax. For a tension pneumothorax, what you will be doing? For tension pneumothorax, you need to decompress it first. How do you decompress? Decompress the right side is the right answer here. How do you decompress? We have two options to decompress, either by doing a finger thoracotomy or by doing a needle decompression. Out of these two following, finger thoracotomy is the preferred one. A 61 years old male was involved in a high-speed road traffic accident. He sustained an injury to the head. Paramedics at the scene have done a 3-point immobilization of the C-spine and brought to the emergency department. Other head injuries, other than head injury, the patient doesn't have any other injuries. The primary service unremarkable. Which one of the following is not an indication to get a CT scan done within an hour's time? More than one episode of vomiting? Yes. Focal neurositis? Yes. Seizures? Yes. Base of skull fracture? Signs of basal suspected basal skull fracture is an indication to get an immediate CT scan. That is within 1 hour. Retrograde amnesia for 30 minutes? No. So the right answer is the fifth one. A 34 years old was brought to the emergency department with a stab injury to the abdomen 6 hours back. On arrival, you are connected to the high flow oxygen. Breathing seems to be fine. Borderline blood pressure, 1 liter of bolus you are given. 90/50 the blood pressure is. GCS is not less than 9, so not thinking of it intubation. The most appropriate next step in management of this patient is. So what kind of, do we need to get an EFAST done? No, it is a stab injury. So what are we doing? In EFAST, we are looking at the fast free fluid if present, laparotomy. It is not required. There is a direct indication if the patient has an penetrating injury and hypotensive, directly goes to the laparotomy, that is directly goes to the operation theater. So this is not required. CT abdomen, I cannot get it done because the blood pressure is 90/50, not 90/60. 90/60 is the normal blood pressure or okay blood pressure. Tranexamic acid. Tranexamic acid, we give it if the incident is less than 3 hours. It's been 6 hours, so no tranexamic acid also. Bedside chest X-ray. Just the bedside chest X-ray, we're not thinking anything wrong in the chest. The stab injuries to the abdomen. So getting a bedside chest X-ray will not be helpful in these circumstances. So what we'll be doing? We'll be giving more fluid because still the patient is in shock. The blood pressure is not 90/60, it is 90/50. For this reason, we are giving more IV fluids. So the right answer here is the third one. Remember that tranexamic acid is given if the presentation is less than 3 hours from the incident. It is more than 3 hours, it's 6 hours here. For that reason, we are not giving tranexamic acid. A young boy seen in the triad presented with an history of fall from his bicycle. He sustained an injury to the abdomen by the cycle handlebar. On primary survey, a bruise was seen over the abdomen. His vital parameters are stable. He is complaining of pain. Nurses admission intranasal dimorph. What is the most appropriate next step? The appropriate, do we need to get in fast scan done? He's stable. Why do we want to get in fast scan done? IV fluid not required. Surgeon reference, no indication. Tranexamic acid is stable. You're not activating major amylase protocol. You're not resuscitating the kid. But there is a bruise over the abdomen because of cycle handlebar. You can directly go ahead and get an CT abdomen done for this patient to see if the internal organs are fine. So you can shift this patient out of the emergency department to get an CT scan done because the patient is stable. So the most appropriate next step is to get a CT abdomen done directly. Fast scan will not rule out any subtle injuries. Especially in the pediatric age group, it is not recommended to depend on the fast scan because you need to have minimum of 200 ml of free fluid in your abdomen to be picked up on the fast scan. Otherwise, it doesn't pick up. A 200 ml in a young boy, is a large amount of fluid. So you cannot depend on this. So you are getting a CT scan done. If ultrasound is the option, fast scan is an ultrasound, what you're having, so you're not getting it done. Ultrasound scans are not sensitive enough. Okay, in an adult also, it's not sensitive enough. You need to have 200 ml of free fluid in the abdomen. So fast scan is done when the patient is unstable. If the patient is stable, go ahead and directly get NCT abdomen done if you're suspecting anything is wrong in the abdomen. A 22 years old male was brought to the emergency department by his teammates. While playing football, he sustained an injury to the head. He had a brief loss of consciousness. Oral codeine was being given for mild headache. He denies any other injuries. Any other injuries. His observations are within normal limits. A CT scan of the head was done and has been reported as normal. You decide to discharge the patient with the safety netting. The patient wants to know when can he resume playing football. What will be your advice? When can he resume? After 3 weeks, that is what 21 days. This is according to the NICE guidelines. 3 weeks, you shouldn't have any contact sports like rugby, football. Those are all contact sports. You shouldn't play for 3 weeks. So the right answer is the third one. A 13 years old boy was involved in a road traffic accident, sustained a blunt abdominal injury. Paramedics have gained IV access and administered analgesia en route to the emergency department. On arrival to the ED, the patient continues to complain of abdominal pain. No life-threatening injuries were found on the primary survey. You go ahead and get a polytrauma scan done, which is reported as normal. Which one of the following organs cannot be detected, or injuries of an organ which cannot be detected on the CT scan? Is the pancreas. Pancreas is a retroperitoneal structure which does which is very difficult to pick it up on the CT scan. Most of the time, any injury to the pancreas cannot be picked up on a CT scan. If you're suspecting a pancreatic injury, we usually admit. Why do we admit? We admit to get a series of pancreatic enzymes. Okay, that is basically lipase and amylase, what you will be getting it done. Okay, series of lipase and amylase, you will be getting it done to see whether there is elevation of pancreatic enzymes. Over the time, if the pancreatic enzymes are elevated, it is suggestive of a pancreatic injury. That's how you will be knowing. So pancreas is the organ what you need to be aware of, which any injury to this organ cannot be picked up on a CT scan. A 40 years old female was brought to the ED with a stab injury to the abdomen. On examination, noticed a stab just below the umbilicus. No active bleeding is noted. 1 liter of fluids and PRBCs were given. On assessment, the patient, there is some amount of tachycardia, hypotension, tachypnea is present. What is the most appropriate next step in the management? They are asking. You need to consider stab injury, penetrating injury, hypotension. That itself is an indication to get an laparotomy done. So first thing in circulation we always see is to stop the bleeding. How can you stop the bleeding here? By getting a laparotomy done. So shift for an urgent laparotomy for this patient. A 56 years old male was involved in a low speed road traffic accident. The patient sustained a head injury and has a loss of consciousness. He denies any other paresthesia or limb weakness. CT head was done and reported as normal. After coming back from the CT room, the patient complains of neck pain. So it is a delayed onset of neck pain. Which of the following will be the most appropriate next step? There is age is not 65 or more than 65. No dangerous mechanism of injury is present. Along with it, there is no paresthesia which is mentioned of the limbs, and there is a delayed. So no high risk factors. No high risk factors for this. Are there any low risk factor? At least one low risk factor I need. There is a delayed onset of neck pain. Yes, one low risk factor is present. That is enough for me to check for lateral rotation. So you will be directly going ahead and checking for the lateral rotation. Check for C-spine middle line tenderness, not required at all because you have already one low risk factor here that is sufficient for you to go ahead and check for lateral rotation of the neck. Okay, one low risk factor which is present here, that is delayed midline tenderness. So you'll directly jump to check for the lateral rotation. A 24 years old male was involved in a road traffic accident. He has fallen down from the bike head first. He complains of severe pain over the face and neck, especially the back of the neck. His vital parameters are kind of stable. You immediately put out the trauma call. An image of the face is shown below. Which one of the following will be the next step? Next step is fifth one here, as discussed previously. Manual inline stabilization is the first step. Second step is doing an airway assessment and intervening if required. Third step is 3-point immobilization. If they mention just C-spine immobilization, also we'll consider it to be an manual inline stabilization. A 40 years a 40 years old male was 40 years old came to the ED along with his partner. He sustained multiple blows to the face as he was involved in a bar fight. He complains of painful eye movements in the right eye and requests a painkiller. The triad nurse has secured the IV canal. Analgesia has been administered according to the local protocol. An image of the face is shown below. What's the most likely cause? Most likely cause painful eye movements. There is a proptosis which is present. Punch has happened. There is a bruising of the eye. So what are we thinking of? Retrobulbar hematoma. So the right diagnosis here is retrobulbar hematoma. Can it be an orbital cellulitis? Unlikely. Do not choose an orbital cellulitis in a setting of in a setting of a trauma. In a setting of a trauma, always think of retrobulbar hematoma. If there is no trauma and this is the presentation, then you can think of an orbital cellulitis where the presentation will be quite similar. Painful eye movements will be present, proptosis can be present. But orbital cellulitis in a non-traumatic case, you need to suspect. An elderly female has slipped and fallen down in the triage area. In triage area itself, she has fallen down. Complaining of shortness of breath, she is taken to the resuscitation room, immediately connected to the cardiac monitor. On assessment, reduced air entry is noted on the right side and the trachea is deviated towards the left side. Her observations are following. There is an tachycardia and tachypnea with hypotension. What is the most appropriate next step they are asking? So trachea is deviated to the opposite side, air entry is reduced. So all these parameters, hypotension, tachycardia deviated, and this one is suggestive of an tension pneumothorax. The best treatment for tension pneumothorax is a finger thoracotomy. The first step is finger thoracotomy. Once you are done and finger thoracotomy, relieve the tension, then it converts into simple pneumothorax where you will be placing an intercostal drain. A 22 years old male, while playing boxing, sustained an injury to the head. He had a brief loss of consciousness. He denies any other injuries. A CT scan of the head was done, which has been officially reported as normal. He has an important tournament coming up in 2 weeks. The patient wants to know when he can resume playing playing boxing. Blocking is a contact sport. Any contact sport needs to be avoided for 3 weeks. 3 weeks is 21 days. Tell him 21 days you're not allowed to play contact sports. A 51 years old female was involved in a road traffic accident. A head-on collision with another car. She was driving the car with the seat belt on and sustained injury to the neck. You have received the patient in the resuscitation bay, connected to an cardiac monitor and has been served the analgesia. On examination, our vital parameters are within normal limits. The power of upper limb is 3/5, lower limb is 4/5. So weakness of the upper limb is greater than that of the lower limb. Here only we are thinking about central cord syndrome. Okay, along with head-on collision with driving seat speed and on, that also kind of suggestive of in central cord syndrome. That is the most commonest mechanism of injury. That is an hyperextension decelerating injury. So right answer here is central cord syndrome. A 40 years old male accidentally slipped on the wet floor of the bathroom floor and sustained an injury to the face as shown in the image. He denies any loss of consciousness or vomiting. On examination, he is stable. His lower lip gets deviated to the opposite side on smiling. So something is wrong with the motor function. Which branch of the facial nerve is involved? This is the fifth one. It is a difficult question. This should have been asked in the primary exam, not in an XP exam. But marginal mandibular branch of the facial nerve, which is involved, you need to be aware of. A 13 years old kid sustained injury to the face while playing cricket with his friends. He used no history of loss of consciousness or vomiting, present to the MS department along with his parents with an avulsed tooth. His observations are within normal limits. Debris was noted around the tooth. It's been approximately 20 minutes since the injury. What's the best option? Implant it. Before implantation, gently clean it, then re-implant it is the right answer. A 29 years old male presented to the ED after sustaining multiple blows to the face as he was involved in a bar fight. 2 to 3 days back, he complains of painful eye movements in the right eye. He denies any other other injuries. His observations are as follow, which are completely stable. What's the most likely diagnosis? Trauma case, painful eye movements. You're thinking of retrobulbar hematoma. So trauma plus painful eye movements. Always think of retrobulbar hematoma. Do not forget. A 20 years old male was involved in a bar fight, sustained multiple punches to the face. He was brought to the ED by the police and is under police custody. Complains of pain in the right and double vision on looking upwards. You offer him analgesia. What's the most likely cause for the presentation? Double vision on looking upwards is suggestive of an entrapment of the inferior rectus muscle due to the fracture of the floor of the orbit. So orbital floor fracture, what you are suspecting in this individual. A 6 years old kid was brought to the ED with an accidental spill of beverage over the face and neck. The total surface area involved burn is 6%. The patient denies any difficulty in breathing or swallowing. Intranasal dimorph is administered for the pain management. Observations looks quite stable for the kid. Might be because of little bit pain, tachycardia is there, but grossly looks normal. What is the most appropriate management plan for this patient? Do we need an intubation for this patient? No, not required. Discharge with no follow-up. It is a phase which is involved, so it requires a follow-up. IV fluid resuscitation might have been required if the percentage body surface area was 10%. Then you will be using a modified Parkland's formula to resuscitate. IV fluid according to no. Resuscitation also no because not hypotension. Keeping all this in mind, the only thing left is by ruling out is referred to the plastic surgeons, mainly because this is a facial injury and it is a kid. That's why you need to refer. Okay, ideally, you need to refer to the burn specialist. Actually, burn specialists are nothing but plastic surgeons who have specialized in burns. That's all. So they are also plastic surgeons. So this is the right one. Parkland formula you're giving, if the percentage of burns was 10%, in a pediatric age group, 10% at least minimum should be present, if I'm not wrong. Okay, 10% should be present. It's not 6%. A 39 years old male was involved in a road traffic accident. He was brought to the emergency department by paramedics. On assessment, the airway is patent and open wound. Important. Open wound over the chest is noted making a bubbling sound. So we are aware that it is an open pneumothorax. His observations as follows. Stable. Okay, so we are not doing finger thoracotomy. It is not intention. So what is the most appropriate next step is to do a three-way dressing because it's an open pneumothorax. Elderly female was walking her dog and suddenly dog dragged her, resulting in a fall. She complains of pain over the left side of the chest. She is a known case of hypertension and diabetes. On examination, the vital parameter seems to be fine. Tenderness over the left side of the chest is noted. Chest X-ray is shown below. What's the most appropriate next step? Chest X-ray, clavicle fracture. Multiple rib fractures are seen. 1, 2, 3. Grossly, what I can make out here, here, and here. So multiple rib fractures and this, you need to admit this patient for the pain management, physiotherapy. Basically, you're admitting best pain management is intercostal nerve block. ICD insertion. Does this patient requires an ICD insertion? Unlikely this patient requires an ICD insertion because this shadow, what you are seeing because of the heart, not because of the fluid accumulation. So ICD insertion is unlikely to be required here. Nothing is suggestive of a pneumothorax. That's why you're not doing any compression. So you're closely having a look here. Nothing, no air is accumulated anywhere here. Okay, keeping those things in mind, this is just the rib fractures what are present. That's why you are doing in pain management with the physiotherapy. So the second one is the right answer. A 34 years old male was involved in a road traffic accident. On primary survey. The patient airways patent breathing is adequate. Circulation wise, hypotension is present. And this is the X-ray given. They have asked what is the next step. X-ray is suggestive of a vertical shear fracture. If you're having a vertical shear fracture, what you will be doing? You will be giving an traction, lower limb traction, so that it come back to the normal analytical position. For only open book fractures, we give pelvic binder. Here, pelvic binder is useless. It will not be helpful. So the right answer here is lower limb traction. A young patient was involved in a road traffic accident. He sustained injuries to the head, and on examination, there is a normal range, but on the slightly on the lower side, 67. Blood pressure on the higher side. Pupils are uneven. You get a CT scan done. The CT image shows the following. What is the most appropriate? Crescent-shaped present. It is suggestive of an STH. Uneven pupils are suggestive of an raised intracranial pressure. Most likely, this is an uncal herniation, we call it. Uncal herniation is the temporal lobe getting herniated and causing compression over the mid, sorry, mid part or mid zone of the brain, resulting in compression over the third cranial nerve, which causes one pupil to be dilated, another pupil to be constricted. Here again, you need to prevent the secondary brain injury, head and elevation to 30 degrees, what you're supposed to do. From here, what questions we are asking or dealing, these are the new questions, not the recall questions which are repeated. These are the new questions which are appeared in the last diet. Last diet in the sense in September 2024, recently we just completed, it has appeared. I want all of you to participate. You can, if you want, you can message on the meeting chat what you're having. If you want to answer verbally, you can answer it verbally. I want all of you to participate so that it is more interactive, because these are the recent questions which have appeared. If you can answer this, you'll develop more confidence. For that reason, I want it to be more interactive. A 23 years old male was involved in a fight and got stabbed in the center of the chest. He was brought to the emergency department in an ambulance. The patient was received in the resuscitation bay and connected to the cardiac monitor. A stab wound is noted over the chest. The vital parameters are there is some amount of tachycardia, but blood pressure is fine. Oxygen is only 90% on high flow. A 30 degrees. A portable X-ray is shown below. What is the most appropriate next step in the management? Anyone, what is the most appropriate step? One of you is telling intubation. No, it is wrong. No, it's not an intubation. Selling up chest drain insertion. No, not selling up chest drain insertion. What, anyone? IV fluids. No, wrong.
Open chest drain.
Yes, open chest drain is the right answer. Let's break it down and see what we are having on this one. This is an pneumothorax. Whenever we have a pneumothorax, we need to see whether the pneumothorax is in tension or not. The main thing what we look at is the blood pressure. If the systolic blood pressure is less than 90, then it is a tension pneumothorax. If not, not a pneumothorax for you. This is not an tension pneumothorax. It's just an traumatic pneumothorax what you are having. How do we treat a traumatic or a simple pneumothorax? By placing a chest drain. But do we use an Seldingham's technique or do we use an open chest drain? Open chest drain is always preferred because you need to, in a trauma case, you need to put a large size chest tube. You cannot place a small size chest tube. Only small size chest tube can be placed with this technique. That's why open technique needs to be done in a trauma case. A 39 years old female was involved in a road traffic accident complaining of shortness of breath. She is taken to the registration room immediately and connected to the cardiac monitor. An assessment reduced air entry is noted on the right side and trachea is deviated to the left side. Her observations are as follows. Unstable it is. So you're suspecting a tension pneumothorax. The diagnosis is given. Needle decompression is done at which anatomical site? It is a very easy, straightforward. So which anatomical site you will be doing? It is the fifth intercostal space, mid-axillary line. So everyone, fifth intercostal space, mid-axillary line, not anti-axillary line. It's a mid-axillary line. Just anterior to the mid-axillary line. It's not anti-axillary line. So this is the right option. The fifth one is the right option. Sorry, the fourth one, that is the fifth intercostal mid-axillary line, is the right answer. A 7-year-old child was playing on a trampoline and fell down. His entire axle load was on the head and neck. The kid is received in the pediatric resuscitation bay. The primary survey is unremarkable. Kid complains of neck pain. On examination, there is cervical spine tenderness. Analgesia is administered according to the local protocol. What is the most appropriate next step? What you will be doing for this patient, what will be the next most appropriate next step is to get an MRI scan done. Okay, to get an MRI scan done is the next best step because of this. There might be a spinal cord injury without any radiological abnormality. So get an MRI scan done. Always an MRI scan for anyone according to the C spine requires an C scan. So is it a dangerous mechanism of injury? Yes, there is a dangerous mechanism of injury because axle load was there. So according to the Canadian C spine rule, this kid requires an imaging. In a child, the imaging which one preferred is an MRI scan. The same patient, if I change the age, for example, 37, then the scan becomes a CT scan, not an MRI. But because it is a child, it is an MRI scan, what you're supposed to get it done. A 24 years old male was involved in a bar fight, has been stabbed in his back. He is brought to the MS department in an ambulance. Ambulance on examination, the airway is patent. His high flow oxygen is connected. The hemodynamic stable. CT polytrauma is done. Shows right-sided spinal cord injury. You're suspecting Brown-Sequard syndrome. Which one of the following is expected to see in this patient? Which one you'll expect to see? You will basically what you will be seeing. So which side is the stab? What you need to closely look out for? Stabbed in the back, brought to the MS department. High flow oxygen. Okay, shows right-sided spinal cord injury. So the injury is on the right side. If the injury is on the right side, you what findings you will be having, and on the left side, what findings you will be having, you will be looking out for. Okay, on the opposite side, you will be having. Sorry, on the opposite side, there will be loss of pain and temperature. Okay, on the right side, yes, on the same side, there will be loss of vibration, not the temperature. Left side loss of vibration and proprioception, no, it should have been right side loss of proprioception and temperature. Left side loss of vibration and temperature, no, both cannot be on the same side. Same thing also good for pain and temperature, cannot be on the both sides, they have to be on the opposite side. So the right answer out of all this is the second one. This is the Brown-Sequard syndrome, what you're remembering. A 47 years old male fell down from a ladder while he was trying to fix the internet cable. Soon after the fall, the patient started having neck pain and has self-administered ibuprofen and paracetamol without any effect. The junior doctor has assessed the patient and took an X-ray as shown below. The X-ray is shown below. What's the most likely diagnosis? Multiple people got confused between hangman's fracture and clay shoveler's fracture. This is the X-ray what has been, similar X-ray has been given here. This is the C1, C2, and this is the vertebral body. Just adjacent to the vertebral body, there is a fracture, which is indicative of involvement of pars interarticularis. Involvement of pars interarticularis is suggestive of an hangman's fracture. This is the spinous process. If the fracture line was here, then it would have been clay shoveler's fracture. This is an hangman's fracture. So the right answer here is hangman's fracture, not clay shoveler's fracture. Clay shoveler's is the spinous process fracture should be present. A 39 years old male was involved in came to the MS department along with his partner. He sustained multiple blows to the face as shown in the involved in a bar fight. He complains of painful eye movement in the right eye and requests painkillers. The tiredness has acute IV analgesia has been administered according to the local protocol. Image of the face is shown below. What is the most appropriate? There is proptosis, there is painful eye movements, and there is a trauma. Keeping all this in mind, we are thinking of an retrobulbar hematoma. In a retrobulbar hematoma is an acute emergency. You need to immediately do a lateral canthotomy, otherwise there will be complete loss of vision. So the right answer was lateral canthotomy. A 19 years old male was involved in a street fight which resulted in multiple punches to the face on his face. Double vision on upward gaze. The primary surface unremarkable C-spine has been ruled out according to Canadian C-spine rule. X-ray of the facial bone is shown below. What's the most expecting on the examination of this patient? So right side thickness is much more than the left side, so suggestive of an right orbital floor fracture. Infraorbital nerve is present here. So injury to the infraorbital nerve will result in loss of sensational over the nasal septum. So the right answer was first one. It has no motor effect. That is a sensory nerve. So you will not lose any nasolacrimal fold, which few of them selected. No, it is not. Only the sensation part is which is present. Ophthalmologist, you will not be referring. As an emergency physician, you are supposed to be qualified enough to do an lateral canthotomy. It is an acute emergency. You are expected to do this procedure, not an ophthalmologist. A 31 years old male was involved in a road traffic accident. He was fallen down from a bike head first. He complains of severe pain over the face and neck, especially back of the neck. His vital parameters is kind of stable. You immediately put out the trauma call. Image of the face is shown below. What's the most likely next step? Here, what is the first step what we do? Manual inline stabilization. Manual inline stabilization, has it been mentioned here? No, not mentioned. So first step is gone, or we'll assume they might have done it. Next step is to assess the airway. On assessment of the airway, bad facial injuries, deformed face is present, so requires and prophylactic intubation. Though the airway might be present now, will get compromised in later on. That's why you need to intubate this patient. Who will intubate? Anesthetic, because you're suspecting a difficult airway. So anesthetic reference for intubation is the right answer here. Finger thoracotomy, tension pneumothorax is not. This is also wrong, obvious wrong answers. 3 points C-spine immobilization is the third step, is the 3-point C-spine immobilization. A 27 years old female was attending a concerned unknown person has stabbed her abdomen. Paramedics have brought her to the emergency department. Paramedics say unremarkable abdominal wound is noted over the umbilicus. Erect abdominal X-ray is taken and shown below. What is the most likely diagnosis? On an erect abdominal X-ray, what you are seeing is air under the diaphragm. Air under the diaphragm is suggestive of a pneumoperitoneum. Why air under the? Because of the stab injury, most likely hollow viscous organ has got injured and the air has escaped. That has resulted in accumulation of the hair just below the right diaphragm, in between the diaphragm and the liver. This is pneumoperitoneum. Long time back, there was an CT scan image what they had given, and they wanted you to comment on the CT scan image. We are not sure what exactly the question was. So little bit more about the abdominal CT scan what you are having. This is the normal parenchyma will appear. The liver, this is liver parenchyma will appear in this manner. Okay, this one what you are having is the spleen. Spleen uniformly it will be, and this is known as parenchyma. Next thing what you need to remember is this. This, do not think this is a lesion. This is the gallbladder what you are seeing. Okay, this is not a lesion. This is a gallbladder what you are seeing here. If there is a lesion, what happens? If there is a lesion, there will be uniformity of the lung parenchyma will be lost. It will start appearing darker in color. You can see this part is appearing darker in color. This part is appearing darker in color. This is the splenic injury, the lacerations over the spleen which is present. They are different grade in grade 1, grade 2, grade 3, grade 4 lacerated wounds, whether there is active bleed, inactive bleed, depending on the arterial phase or venous phase. That is for the radiologist. We need to just pick up that, are you seeing something abnormal? Yes. What is the abnormality? The lacerated wounds, what I am seeing, basically injury to the spleen, what I can appreciate here, because the parenchymal abnormalities have been lost, or the parenchymal uniformity is lost. Here, obviously something is wrong here. Sorry. Something is wrong here and here. What you need to comment on. So that ends the trauma class. Extensively, we have discussed the questions here. Someone has a question. Can you please explain the question 87 and 87 regarding the infraorbital long floor of the... What is your doubt? You can unmute and talk to me and tell me what is your doubt. Because me explaining again and again will not help you.
Sir, I think it's the next question. In the infraorbital nerve was the option. Yeah, this one.
So what is your doubt
Um,
here?
it's the nerve inferior to the eye and lateral to the nasal septum will be affected, right? Nasolacrimal fold.
No,
No.
it will involve the septum also. It will involve the septum and this whole part will be involved. The septum
Okay.
is also
Okay.
supplied by infraorbital now.
Okay. Thank you, sir. Thank you.
Okay, another one of you having types of ICD. There is no types of ICD. The techniques are different what you're placing. There is a Seldingham's technique. There is an open technique. Different sizes of ICD will be coming. For example, there might be an 18, a very small one what you're placing, or 22, 24, up to, I think, maximum, if I'm not wrong, up to 24 French, you can place it within Seldingham's technique. For a traumatic case, you need a larger one, 30 at least minimum, if not 32 or 34 French size, what you'll be placing in a traumatic, because you're expecting some amount of blood will be there to drain it. You need a large one. For large one, you need to do an open technique. Seldingham's technique is not possible to place a large ICD tube. Children with neck trauma, if imaging is indicated straight away, MRI scan, yes, it's a straight away MRI scan. If according to Canadian spine rule, there is an indication you're getting an MRI scan done, not a CT scan done. The question answered with chest discompression, why was diagnosed as a pneumothorax, not hemothorax? You need to tell me which question. Question number is important because we discussed plenty of questions. So open ICD in trauma, even if hemothorax, yes, obviously. Is the open ICD what you're placing because you want to drain it blood? You need to obviously get it. Unmute yourself and talk to me if you're having difficulty in typing. Because we'll be ending at the class if there are no more questions.
Yes, hi, please. Just I'm asking if
Yes, please.
if you have a patient and we are doing for him operation, and during the operation there is a massive bleeding, and the patient receive 5 units of blood. When we say this is a massive hemorrhage, and according for the blood transfusion, when we can say this is a massive hemorrhage.
Massive hemorrhage. Are you talking about massive hemothorax or you are talking about
Massive hemorrhage as general. If the patient is
any
receiving
patient who
5
is
units.
hemodynamically compromised, that means anyone who has a systolic blood pressure less than 90 is considered as an hemorrhage. If you're asking me what is massive transfusion, there is a different definition for massive transfusion that we'll be discussing in coming up chapters.
Okay, thank
Okay,
you.
if you're asking me when to start and or when to activate a major hemorrhage protocol, you'll activate a major hemorrhage protocol. Anyone has an hemorrhagic shock, and anyone who has an hemorrhagic shock, you'll activate a major hemorrhage protocol. What is massive transfusion? That is a completely different definition. When you would have transfused at least 10 units, those kind of definitions we will be learning in coming up class. Any other questions, anyone? Okay, if no questions, we'll be stopping here. Last time, anyone, any questions, you can ask me. Otherwise, we'll be stopping here. So one of you were asking why not pneumo or hemothorax. Mainly pneumo and hemothorax, we will be differentiating looking at the neck vessels. If neck vessels are distended, it is a pneumothorax or cardiac tamponade. If neck vessels are completely collapsed, then chest lesion wise, it is a hemothorax because blood is getting accumulated in the lungs. That's in the pleural space, sorry. Intrathoracic, it is getting accumulated. That's why it is in hemothorax. Pneumothorax and cardiac tamponade, the pressure in the chest is so high that the venous returns gets obstructed. That's why you see distended neck vessels and you see distended IVC, inferior vena cava, and the superior vena cava both gets dilated. That is the main differentiating factor what we'll be looking in the stem of the question. I don't see anyone asking any questions. Yes, please go
Sir,
ahead.
regarding 87, ophthalmologist, lateral conductomy, what is this? Yani done in trauma?
It is a procedure which needs to be done by the emergency department. Lateral condomy, as explained in the class, you'll be putting a lesion or incision over the lateral side to relieve the pressure what is there. It's a simple procedure which is expected of emergency physician to be performed.
Oh, okay. Simple procedure. Thank you. Okay.
Okay, it's an emergency procedure, acute procedure to be done by the emergency physician.
Yeah, okay. Thank you.
Someone wanted 31 question. What is the doubt of the 31 number 31 question you're having? What is the doubt? If you can tell me, I can help you. So when we are going to use that algorithm of pneumothorax, the 2 centimeters age smoking, when is the appropriate time? We'll explain you. This is not the time. Any traumatic pneumothorax needs an ICD. It's a must. Okay, doesn't matter
So
what
sir,
kind of pneumothorax when we are using is a
the
secondary.
major trauma you taught pneumothorax, that is only for the traumatic cases we should learn, and that is separate
Yes.
when later on we will do, right?
Yes.
Okay, thank you.
This is not primary pneumothorax we are talking about or secondary pneumothorax. It's a traumatic pneumothorax. What we talk about is a trauma class what we are having. So do not get confused in the both. Someone had a question, wanted to clarify of the 31 question. What clarification you require, anyone? All right. I don't see any responses here. So we'll end the class here. Thank you, everyone.